And welcome back to the Murdy Creative Co podcast. I'm your host, Colin Murdy, and today we're doing a special episode called The Good Intentions Paving Company and the Modern Medical Hell. Today I'm here with my father, Dr. David Murdy, and we're going to talk a little bit about how we got to the current medical nightmare that is medical billing and mega hospitals and all of the things that go into that, because it is an interesting story. And unfortunately, it's a very important topic for both me personally, having just had a child, as well as millions of Americans out there who have to deal with crazy billing and complicated systems and things that don't seem to work quite right. And it's an easy call of the siren to say there's a simple solution out there, but I think we're going to talk about how it's not a simple solution because it's not a simple process that how we got here. It's a complicated process.
It's only a nightmare, Colin, if you either have to find your way through it, understand what they tell you, pay for it, and then live with the consequences of it.
Yeah, if you don't have to do any of that, it's just fine. Yeah, it's not so bad.
It's working pretty well for a lot of.
Well, and there's always just the option to die. You know, that's always the easiest and cheapest option out there. So,
well, that's true.
Dr. Murdy, where do you come from? Tell us a little bit about your background.
Okay, so I grew up in Rock Island, Illinois, which is at the confluence of the Quad Cities and the Rock Island Line, a West Coast oriented train. Where a lot of the lumber that came out of Wisconsin was floated down the river where then it could meet the rail lines to rebuild Chicago and other places out east. I went to high school there, and then after that went to college at the University of Chicago for 7 years and 3 degrees. Obviously college, but also then graduate school in human biology, which is part of the Pritzker School of Medicine, and in a program called the Arts and Sciences Basic to Human Biology and Medicine. And then as a part of what we were anticipated or expected to do within that ASHM program, I finished an MBA from what's now called Booth Business School at the University of Chicago in healthcare administration. So that was 7 years and 3 degrees and a whirlwind of interesting times. A lot of my interest then was in health policy, which is what we're going to talk about today. After that, though, as opposed to becoming a hospital administrator, I then finished medical school after my first 2 years at Pritzker at Brown University in Providence, Rhode Island. And that was a wonderful experience, me oriented towards primary care. The environment at the University of Chicago is very specialty and research oriented, great for understanding the basics of medicine, but not so good if you want to be a primary care doctor. At the time I was there, the University of Chicago's medical school had no family practice department, and most of the people in what I am in, which is in internal medicine, went on to specialties. Brown was very much oriented towards primary care, and it was an incredible environment where at that time the medical school was building. A relatively small number of medical students were spread across 2,400 hospital beds throughout the hospitals that were cooperating in that program. And we had firsthand experience at a level that many people wouldn't get till much later. I then stayed in Providence and did my residency in ambulatory internal medicine at the Rhode Island Hospital, which is a very unique hospital built with a lot of Newport money from 120, 130 years ago. In fact, the bank that I put my first paycheck in was the Rhode Island Hospital Bank, built with Newport money. And it obviously had its offices in the base of the hospital. It was a wonderful place to learn. It was a 700-bed teaching hospital in the middle of the city with a private hospital next to it where a lot of cardiac and cancer care was provided. And it was a wonderful educational mix where we had a great deal of responsibility at a time when you were on call essentially every third or fourth night for the 3 years you were there. And then I left Rhode Island and went to work in Wisconsin, in Janesville, in a group at that time called Riverview Clinic, which was along the Rock River, the same river we're near now. And at that point, practiced internal medicine and later geriatrics, getting an additional certification in geriatrics at the behest of my preceptor from Rhode Island. His name is David Rubin, and he's now chairman of geriatrics at UCLA.
Well, in Riverview, if I remember correctly, the structure of the hospital was somewhat unique in that you guys all had a little bit of buy-in, and so there was a role to play in administration and decision-making amongst some of the partners in decision-making.
Yes.
So that administration education was able to be utilized in practice as well, right?
Yes. I mean, it was a physician-owned 45-doctor clinic, later absorbed into 350 additional doctor clinic in Madison called the Dean Clinic, both established more than 100 years ago. Most of them, I would dare say, on the Mayo Clinic model, which would have been now 140, 150 years in development. Then later merged into even larger systems as we acquired hospital organizations, HMOs, insurance arms, and all of those things to try to ambulatory surgery centers, all of which to try to improve the care of our patients and to see that they could get the care they need, hopefully at an affordable cost.
Excellent. So, I mean, that's a lot of practical application, and we're going to continue on with the story. But first, I want to say thank you to everyone who's supported the Murdy Creative Company. This episode is brought to you by the Murdy Creative Company. Check that out, murdycreative.co. We are actually reading out of and working out of notes that we've taken in our leather folder, and Dad's got an executive cut folio that he's got his legal pad in for this episode. So it's great products. It's amazing, made in USA leather products that are backed by our 120-year warranty. So thank you for everyone who's supported the company so far. If you want to get a chance, go check out murdycreative.co. Now, one of the things that I've always found very interesting about your background is obviously you've got a lot of education at University of Chicago in healthcare administration. You obviously did a residency and your continuing education at Brown, very respected school, and obviously Rhode Island. And then obviously you've been practicing for quite a while. And I grew up with the wonderful pleasure of listening to you talk about the many challenges that were happening in some of the administration and some of the operations in hospitals. And I think at the time you've had various leaderships and various organizations that you've worked under with different models and differing attitudes towards both patient care and the financial side of it all. But I want to roll back the clock quite a ways and realize, because for people my age, we've always known that medicine means you go to the doctor in the hospital, which is this enormous building that is a sprawling campus with, enormous rooms, and there's all sorts of stuff. That's what we know of as the doctor. And then obviously there's the insurance side of it, and that's where everybody works on getting their job so they can get insurance for the most part, it seems. And I have friends of mine who they intentionally went to pick jobs because they knew that job had good healthcare benefits. It wasn't about the pay because of their life circumstances. And so I want to roll back the clock a little bit and go back, 100 or so years or more, and talk about what did medicine look like before and how did it evolve from that point to where we are now?
I mean, it's important to look back longer, because if you tried to understand the system in America without understanding the history of its development, which obviously parallels the history of medicine's expansion and all the marvelous things it can do now, you would sit there and be completely unnerved by how on earth did we have a system that works like this. Medicine 100 years ago was really quite a different kind of thing. First of all, the majority of what physicians could do is to provide prognostic information. They could understand a disease course, its natural history, and explain to you what likely would occur to you and what potential homeopathic or very simple remedies might help someone feel better, while most of the time nature healed the disease, because we did not have powerful tools. 140, 160 years ago, when anesthesia became more commonplace, as you had pointed out earlier, it was the speed of the surgeon that helped because of the reduction in bleeding, the reduction of pain, because anesthesia was in its infancy. So to trying to do operations on someone, even pulling a tooth without anesthesia, is a gruesome and difficult event. And I
didn't realize, as you pointed out, that they aren't part of the Hippocratic Oath, because they were originally, at that point, considered technicians. It was a technical skill like being a plumber or an electrician.
We're only going back 100 years, not 2,400 years to Hippocrates. So again, that was often a cash or a barter kind of system. People saw their care at home because that was the safe place to get care. There was no typical office. I mean, you may see TV shows with the doctor having an office, above the saloon or whatever happened to be on TV. But for the most part, physicians made house calls, and that was they would often ride a circuit or be in a buggy in a wagon, or later they might be the only people in the community who had a car, so that they could get around to do that kind of work. And that would include your grandfather, my father, who had pneumonia when he was a teenager, which would have been in the Depression. And at that point in time, he stayed at home. There was no antibiotics to give him for the pneumonia. And you would be terribly sick with fevers and chills. And if you got past the crisis point of a pneumonia, which typically is at 7 days, your immune system had obviously identified the organism by that point in time. We've now learned this later, and then been able to cure it. And you would get better. Now, you might have scars on your lungs, which your grandfather had, which kept him after boot camp in the Marine Corps out of being deployed into the Pacific at the end of the Second World War, where he might have been involved in what was going to ultimately be the invasion of Japan. So that was essentially the nature of care, 100 or so years ago. And in hospitals, by the way, a Christian innovation, because they didn't really exist, and if you need to know the reference for why they were existing, is look up Matthew 25:40, where, Christ asks us to do for the least of these. And that's often what hospitals were. They were charitable organizations, often Christian-based, and they were often for the care of the sick, the destitute, and the near dying, because there weren't a lot of other things that could be done for them. They were, in some ways, a public good. Obviously, healthcare has developed a lot, even more than 100 years ago. The Mayo brothers in Rochester, Minnesota, were pioneers in many different forms, but particularly in surgery. And if you think about it, how could you create a healthcare system that is so large and so complex as the Mayo Clinic, which, as I pointed out earlier, was the model for many of the multi-specialty clinics in the Midwest? It was because they were the pioneers of varicose vein surgery. So wealthy people, mostly women, could get on a train from the east, where, again, the population was largest, or Chicago, and ride for then a relatively rare thing, an elective procedure. Most surgeries were not elective. They were emergencies. They were battlefield amputations in the war. And get to Rochester, stay in a nice hotel, have a surgery, maybe stay in a nice hospital there for a few days, or maybe back in the hotel until they had recuperated, and then get back on the train and go back to their lives in the East or wherever it happened to be.
And when would that have been? Like, what time frame?
1880s to 2010, the golden age, the golden era. That was what it was. Keep in mind that the majority of deaths 100 plus years ago were to infections. Life expectancy in 1900 was 45, and the leading cause of death was tuberculosis.
I always was curious when they talk about the mortality, the average age was 45, because obviously at that time infant mortality was a huge part of life. I mean, this is something you read about when you read stories about the pioneers, or you read anything. It's like the odds of you having more than 4 kids and not having either a child die shortly after birth, a mother and child die during birth, or a miscarriage right before what would be conceivably birth. The odds that was it seemed very unlikely that people would have more than 4 or 5 children and not have at least one instance of that happening. And it's interesting. I always talk about how one of the reasons I know this is there's a very famous journal that a guy, I was on social media, he found his great-great-grandfather's journal, and his great-great-grandfather was writing about the birth and subsequent death 8 days later of their child from they were on the prairie. And I was just contemplating how important journaling is in general, because of the fact that we would never have that record if they hadn't written that down. So obviously, just a little plug for the Murdy Creative Company. We've got great letter journals.
And some of the precious journals that we have in our family is a notebook that your Uncle Cletus kept of his wartime air missions as a B-17 tail gunner, including when he was injured.
So beyond that, though, obviously,
those are things where people write things down, and not only is it precious to have that history of the contemporaneous time, but also to have it in their own hand.
Of course. I mean, handwriting is such a cool thing. But just to jump back to the life expectancy, because of the infant mortality, was that something that was counted in that average? And that's so it's possible that a vast majority of people did live into their 60s and 70s, and it's offset by the infant mortality rate? Or do you think that was a relatively appropriate and accurate average life expectancy, that most people lived to 45 or 50 and that was it?
Well, I think it is incorporating to a certain degree the amount of live births, but again, our records and understanding of demographics was perilous. I would argue that if most people made it out of infancy, they probably lived to be older than 45. And remember, that life expectancy had been more or less the same for the previous couple thousand years. And the advent of hospitals and care, again, the Crusaders were the hospitaliers, was important. And a big part of us understanding how modern medicine evolved was germ theory in the 1870s and 80s, sanitation, washing your hands and using antiseptic with Lister. and realizing that I think it was in 1880 where Bayer, a German company, developed aspirin. Still probably one of the most miraculous things of all time for pain control. And
there were quite a few things that Bayer developed in that time period, but aspirin's one of the good things. So when we talk about this history, obviously, at that time, obviously, dying to a bacterial infection or any other similar type of infection would have been a very common occurrence. And it would have been, I mean, tuberculosis obviously is the famous thing from the Old West that we all hear. The Wild West is that everybody dies of tuberculosis, it seems. And we obviously
Holiday in Wood Springs.
Exactly. And we obviously don't die of tuberculosis these days very often, at least especially not in the West, but even I think generally at large, if you're looking at the tuberculosis has a lot of treatment options now. So what was that? How did this evolve from, that era of doctors with a buggy doing house calls and not really being able to do much other than tell you how long you needed to hold on for, to the rise of hospitals and other subsequent
well, the first thing we need to think about when we're thinking about doctor care and hospital care was where they started, because that's important to really understand even how they're organized now. But to realize what changed wasn't so much public health or health care, even as important it is to pull the pump handle off of the cholera epidemic again. And that was the 1860s, I believe.
Should recount what that means.
The public health as we understand it now really began with the development of an understanding of who died where during cholera epidemic in London. And they mapped where the deaths were. And they then said, oh, gee, what's common about this? And what was common about it was how close it was to a well that was contaminated with, again, human waste, as, again, there was poor sanitation in big cities all over the world at that time. And so the fellow who did it was named Snow, and he literally went and took the handle off the pump where the people were getting the contaminated water. The people in the neighborhood who worked in a brewery, who drank beer, didn't get sick and die. They weren't drinking the water, the people who drank the well. And as soon as they essentially stopped that well from being used, the deaths stopped happening. And so that was a very important piece of information, that this wasn't a doctor necessarily treating an individual, but a doctor realizing a menace to the community and doing something about it. And obviously there are plays like, Ibsen's play. You help me with the name, son. But the point is that that's been a controversial issue, and it's still controversial when you think about what we've just lived through in the COVID pandemic. But what made a difference was less crowding in cities, better sanitation, meaning cleaner water, and having better transportation so that more food and better quality food could be brought to people in larger cities. Most of the time this was a city issue of earlier deaths, and that made a bigger difference. Remember, tuberculosis, as an example, we said that was leading cause of death in 1900, had no effective antibiotics until the 1950s. When you grew up, there was still a TB sanatorium in our county, as there is in many counties, where people who had tuberculosis were quarantined, if you will, to either get better or die, because there, again, was limited attention. And again, certain ideas that go back in literature to the Magic Mountain of Thomas Mann, where, again, if you were at higher altitude, think Doc Holliday in Glenwood Springs, Colorado, the oxygen tension was lower at higher altitudes, which is an important part of the tuberculosis bacterium being able to grow. So that would slow the process of the disease, otherwise called consumption at that point in time, because it consumed the people.
And you give them laudanum, which laudanum is a very excellent medication. Was that opium, heroin, morphine all mixed together?
Well, remember,
all the good stuff. Yeah.
Remember, those were, again, Civil War inventions, because the perception was that heroin was going to be less addictive than other forms of opiates that existed at the time. And obviously, you always have to be careful when they say this is the new improved thing and it's going to be less likely to cause problems. It doesn't always work out that way.
So we move from, so obviously as there's the discovery of kind of the concept of what I'll describe as germ theory, and then this concept of sanitation being an important part of health, maintaining both the community's health and the individual's health, the idea that isolation can help keep and curb disease from spreading with these people. Obviously, that I imagine would lead to the rise in what we think of as the modern hospital today, where the idea is we can keep you clean and sanitary. We can change your dressings and your bandages so that you're not continuing
better able to fight off infection
and things like that. So when did we see that? So you obviously talked about how the original version of the hospital was mostly, I'll describe it as palliative care. You mostly went there to
they were private physician hospitals. The first hospital in the town you grew up in was a physician's home, and he would take in patients who could conceivably benefit from medical care and provide it to them there and then. Remember, it's 100 years ago when insulin was isolated as an initial treatment for diabetes. Up until then, realistically, a non-carbohydrate diet was the only thing that could be provided to them because obviously they needed insulin to deal with carbohydrates, and if they didn't have it, they would obviously die. There were a lot of things that were advents in that period of time. Remember in the epidemic 100 plus years ago called the Spanish flu, which didn't come from Spain, by the way, but it had more casualties to that than World War I. So the next major step in this process of understanding healthcare's evolution started in the Depression. So like I said, up until then, doctor care may have been provided in the doctor's, quote, hospital, which may have been an adjunct of his home or at house calls. And then all of a sudden we have the Great Depression and medical demand collapses, as other things did too, because of, prices going down. That's when your grandparents were growing up. They may have, lived on a farm where they still had adequate food, but money was essentially unavailable. And that led to the medical community being in panic as well. And one of the major innovations of that time came out of a unique person in the Dallas area who had been superintendent of public education for the Dallas Independent School System and who was on the board of directors of Baylor Hospital, a very large, prestigious teaching facility in Dallas, saying, we have teachers. They have, at that point, a fairly stable salary. I'm not saying by any means it was lavish. And the hospital offered what was then called the Baylor Plan. The Baylor Plan was for 50 cents a month, $6 a year. That would provide 21 days of hospitalization to a teacher, and I presume by their family. And that was essentially prepayment for services, and that went over really well. And a lot of other companies picked up on that. And later, that became Blue Cross. After that, and 10 or 15 years later, Blue Shield, meaning payment for the doctors, largely surgeons, came into bet as well because of the fact that healthcare was obviously advancing. There was the beginning at the end of that era of time of the beginnings of some of the antibiotics. But the curious thing when I was doing a little bit of research for this is that the motto of the Baylor Plan was, without the Lord, we can do nothing.
That's a good line. That's a good line in general.
That was part of the reason why I joined the organization many years ago, was that it still had its basis of understanding that its Christian mission was a big part of what it does. And you have to understand that most hospitals and healthcare organizations like Baylor were Christian organizations. Their not-for-profit status was part of the fact that they cared for poor and sick, those who could not pay the bills. And that is unique throughout the world in some ways, but particularly when you're thinking about what type of hospitals you have. Now, obviously, there are all kinds of hospitals now, and I'm not saying that you can be a for-profit hospital and be bad, or a not-for-profit hospital and be good. Obviously, one of the leaders of the Ascension healthcare system, which is a very large Catholic health system, basically said, if you have no money, you have no mission, and that is true. So you still have to pay the staff and pay for the equipment and all the things that you had.
Well, and an important thing you just talked about there, which I didn't understand until I had my first child, and I think a lot of people maybe don't have a good grasp on unless they've dealt with it a lot, which is the fact that even back then, and this tradition seems to kind of percolate forward in time to now, the doctors and the hospital were separate entities. They were separate businesses even. They
very much so.
The doctors existed as doctors.
Often is very private individuals running their own little business, and doctors themselves were basically functioned as a guild.
And then the hospital as a building with equipment, and it was, you pay for its services totally separately. For example, we still, like for my wife's epidural for the most recent baby, it was this anesthesiologist billed us at us totally separately from the hospital. So that separation, we don't see it for those of us who go to the hospital nowadays. I mean, and nowadays sometimes they are combined, but sometimes you get bills from two separate groups, it would seem, and it's confusing as to why, or many, exactly, because it's really not one large business that's integrated and organized as one large business. It's many different organizations underneath one roof. For example, the midwives and the OBGYNs, I don't think that they are associated with the hospital that we gave birth in.
They have credentials and privileges at that hospital to provide care.
But they aren't part of that hospital. They're not actually a formal element of that.
They're not employed by nor pay the hospital for the privilege there. They are kind of like in mutual relationship. In 1930, all of healthcare spending in the United States was $2.8 billion. I dare say right now we spend that in an hour nationwide. And it was 3.5% of GDP.
Wow. So the GDP nowadays is
22% of GDP.
Is what we spend now, and how 22%? Okay.
$4.5 trillion.
Oh, good Lord. This is where, when you look at the bigger picture about all of this, like I said before, one of the big challenges is that this isn't just a problem for people paying for their own health care, or this isn't just a problem for people trying to sort out the, odd insurance issue here and there, or the in-network versus this isn't a problem just like that. This is a problem where everybody across the entire sector of every sector deals with this cost. They deal with this in the form of the products being higher cost. They deal with this as their employer is limiting what they're getting paid in dollars because that money is going to insurance companies, right? And the insurance companies that are insuring these people are enormous organizations with an enormous amount of market power, and it functions. I mean, nowadays
we're going to talk about how they got there.
It functions like a cartel to some extent. So,
well, from the earlier mutual insurance days, where we talked about people maybe within a guild or within a profession, woodman is an example. Thinking of your grandmother's line of work initially when she moved to the community. The whole concept of insurance initially, when we're talking about Blue Cross, in some ways was prepayment of a certain level of access, separate from any sense of indemnification. So when you're thinking about insurance, you don't normally prepay for, an accident. You don't, now there is insurance you can buy for car maintenance, but most of the time people don't have insurance.
Brought to you by the health insurance guys.
They don't have prepayment for that. I mean, you pay for car insurance or car maintenance as it goes along. You may pay for car insurance for liability in case you hit somebody or somebody hits you, or as an example, even maybe some medical expenses that may be associated with an accident. But again, most people don't wish to ever have a vehicle accident, and obviously no one wishes to have an injury from that. So in some ways, this prepayment was to the provider's benefit of having essentially some of that cost baked into the revenue stream because, again, of the large cost of operating a large hospital and the associated care that goes with it.
So the associated cost that goes with it, obviously, is an important element of this. And I think when we look at the overall problem, I mean, that looks like the first subscription service to me. I mean, again, I know it's not.
That's a good way to think about it.
It was like the Netflix model that just has taken the world by storm, obviously, which came from the cable package concept, right? This goes back to a subscription service, but for medical procedures back way back when.
Most people would rather not pay. They're more comfortable having it in a subscription model than paying for it at the time of service. When I was a little boy, mother would either call Jane, the doctor's nurse, a wonderful nurse, very nurse. It's like in my mind, that's what a nurse is. And Jane would make a decision. If it was straightforward, appropriate care based on what my mom could tell, Jane would often see with the doctor's permission and call in whatever the appropriate medicine was. If it needed something, I would go and sit in the doctor's office. Sometimes with my mother, when I was older, I would ride my bike and walk in, and I would sign my name in, And I would sit in the waiting room, and Jane would look at who was out there and make a triage decision. If someone looked bad, they got seen before you. And if not, you waited in the afternoon. I think he had appointment times in the morning and Leslie clinic in the afternoon. And at that point in time, you would be seen, and you would walk out and pay at the time of service. And that was just how it was. Insurance was not a part of that type of care for me growing up. And the fees were modest. I mean, I think a doctor visit call may have been $20 when I was in, a young boy, or even, a teenager. I remember still going to him when I was working in construction and cut my hand, one of these scars on my thumb here, with a sheet of glass. And we still called Doc and went to his office at 5 o'clock in the afternoon, because that's when the injury occurred. And he cleaned it out and sewed up my hand, and it's obviously been fine since. And I had the great privilege many years later of giving grand rounds with Doc Cunningham introducing me and his son, who I've also seen in the audience as well, for a medical lecture I gave at that hospital many years later.
Well, and so this is an important point. What was the time period and the cost associated? So, because obviously inflation makes all of this very challenging sometimes to compare apples to apples. And this is where the percentage of GDP is a great way to think about it. But when would this have been a $20 visit to the doctor at the time?
1960s.
Okay, so if we're talking 1960s and $20, it's roughly, you could basically move the decimal point $1 or 1 decimal point. So it's about $200 to go see the doctor, in equivalent dollars. Now, obviously, like I said, there's nuance to this, and obviously various aspects.
$20 was more than a men's dress shirt at the local store when I was in high school, or in junior high, when I was Charlie Colwell and the Music Man at Washington Junior High School, because Mom bought a special shirt as a part of my costume. And we had to go to a fancy men's shop in Moline, because they're the only people who had it, where I had a brown shirt or a brown striped shirt with a starched purely white collar, because that was the style that I had to wear. Fringe cuffs, of course.
And so do you know what that cost or what that was about?
I think it was about $20, because that was a fancy men's shirt at that time. Now, a fancy men's shirt, if you actually paid retail for it, might be 5 or 6 times that. But that was where healthcare was through the Depression, and the initial part of what now is the largest health insurance organization is still Blue Cross Blue Shield, nationally organized in Chicago, but they're in every state. Again, out of a not-for-profit scheme scheme's the wrong word, but concept of how they would provide care throughout the nation. And again, it involves some prepayment of service anticipation, but also preventative care now is an emphasis, but also the idea that some of what you're doing is insurable costs. Like, you don't know you're going to have an appendix that needs to be surgically removed, or a breast cancer that unfortunately needs to be treated, and so forth. The next most important advent happened in World War II. So 1940s, after Japan attacked and the Nazis were busy invading Europe, we became involved in a world war, which required mobilization of vast numbers of men. So I believe we went from an armed forces of less than 100,000 to 12 million. 12 million served. At the time, at the beginning of World War II, 10% of Americans had some form of health insurance. Again, they paid for it out of pocket, just like some people might pay for a volunteer fire department or a volunteer ambulance corps.
Which, by the way, it's an important thing to note. If you're not paying for it, and what I mean by you're not paying for it is it's not coming out of your pocket actively, you're not really the customer. And this is an important thing that all of us know because of Google and Facebook, right? We've all kind of come to terms with the idea that if you're getting something for free or for much lower cost than it really should be, you're not really the customer, you're the product. And when we talk about the future, what ends up happening with where we're at now with insurance, where, yeah, you may pay for a part of it out of your pocket, but you're not by any means paying for the vast majority of the cost. Your business employer is. You're not the customer. And that's an important, and we talked about this at Concordia, and we'll get into this in a little bit, but when I was at Concordia and we did the healthcare summit, we talked about how part of the reason why this got broken is because the doctor who's providing the service, the hospital that doctor is either related to or part of, the insurance that's the one that's reimbursing that group, the employers that are theoretically paying for it, and then the person that's receiving the care, that has so broken the normal provider of service, payer of service relationship.
It's always been complicated because obviously if you were seeing the company doctor on a company work site, because healthcare might otherwise be unavailable to you, the doctor had conflicting motives. He had to obviously care for you as an individual, but his goal was to potentially return you back to the workforce.
Yeah.
And not to say that you didn't want to be returned to the workforce either, but there were conflicting motivations, and that's true of all human nature. During World War II, wages and price controls and rationing came into force, again, for the war effort. Your grandparents had to deal with ration stamps for getting gasoline if they were going to drive a vehicle. For much of that time, they didn't have a vehicle. They took trains to go places. They would communicate if they needed hotel reservations when your grandfather was working as an auditor after he was discharged with a medical discharge from the Marines for an implement company making war material. They would make a reservation by writing a letter, and they would get a letter back, and then they would take the train to that hotel and check in, and so forth and so on. So price controls came into force both because the government was the major buyer of war material.
That's always great when you're in charge of setting price controls and you're the guy buying it. That works out well for you.
And many of those other materials were being diverted to the war effort, whether it was consumables, foodstuffs,
medical supplies too.
I mentioned gasoline and so forth and so on. That was all part of it to help deal with that. And so how do you compete to attract labor if you're a company in a community like this or where we grew up, to make war material where you need labor, you need workers, you need Rosie the Riveters or whoever it had to be. So you couldn't compete on wages. So fringe benefits began to exist where the company would pay for health insurance. Was a big example because it was sought after. People really thought it was a good thing, and I'm not saying it's not, as well as other kind of fringe benefits later. And the government did not consider that part of the wages. So that was paid on top of it. And later, there were IRS determinations that was free to the employee and obviously expensable by the company. And so that became a part of labor.
Tax-free.
It was tax-free to the employee.
So that the benefits that they received in the form of healthcare,
they did not pay income
They didn't
taxes.
pay income taxes on it. So now all of a sudden, and that's an important point to make, which is that was a policy decision. That was a well-intentioned policy decision by the government to say this functionally check that you're not getting, but is the equivalent of dollars that would have otherwise come out of your pocket in the form of healthcare costs. We're going to make that a tax-free income. So now all of a sudden there's a benefit that companies can increase that doesn't increase their taxable income. And for another point is it's not part of payroll.
Right. And that third party was your employer.
Yes.
And so they got themselves into businesses in essence of buying health insurance initially. And then, as we talked about earlier, companies essentially saying, can we make health care cheaper than we can buy health care?
Which, by the way, Quad Graphics in Wisconsin did that. Quad Med exists because Quad Graphics, which is an enormous company that employs a ton of people, figured out it was cheaper for them to build a hospital and pay doctors than it was for them to pay for insurance for their enormous workforce.
And that's what my dissertation was about with Deere & Company. So that fringe benefit also then later became amenable to collective bargaining. So at the end of the war, 25% of the workforce had health insurance through that type of mechanism, only later then to further expand. And that became like a big driver of the healthcare development. In the post-war period of time, there was also the utilization of antibiotics that had been commonly used in the World War, and also other types of care, better anesthesia. All of those things came to the fore. The federal government got in the business of stimulating hospital development through direct grants to build hospitals in smaller communities that might not otherwise be able to raise the capital to build them. And so that was a big part of what happened.
So we saw a rapid evolution of healthcare during World War II, which very commonly major improvements in medical performance happens because the Defense Department is spending an awful lot of money on figuring out how to take care of better cure people in the field and whatnot.
And there was, yes, a lot of advancement in medical care through the war. And that's why, in some ways, unique to our part of the world, health insurance is an employee benefit, tied to workplace. And obviously there's good things and bad things about it as well. But that has become a big deal.
And to that good news and bad news side of that, one of the things about as an employer, because your health insurance is tied to your employer, employers can use that as a methodology through which to compete with each other for labor.
That's what they did in the war. That's how you attracted people. If you were Henry Kaiser building Liberty ships to California at one every 3 days, I believe, it was an enormous and incredible thing. You had to attract workers, and if you did it, you could bring them health care. And in some cases, you brought it directly to them. All right, so this was cool.
And this is where, for me as a business owner, when I think about this, and this is where it's very challenging sometimes for people to contemplate this, because human behavior plays a big role in this. Because one of the things you talked about is that people would rather pay for a subscription service, and I agree with you, in part because people are bad at saving. So this is where, for example,
in health expenses at all times, in the Depression, before the Depression, are always typically large expenses that are random in the sense that it's not like, oh, I'm having a baby. I have 9 months to figure out that I'm going to have a baby, right? But, you have your gallbladder out. You're in trouble. We saw in one of our medical meetings that someone's bill for their gallbladder being taken out. This was after the war. So again, many things changed after the war. There was an incredible price increase, wage increases because of pent-up demand for vehicles, because they had all been used to build in tanks and trucks and other things. A bill, I believe, we saw at a medical meeting for someone's gallbladder, which was hospital, doctor, the whole 9 yards, and I think 5 days in hospital was $200.
Wow. Well,
and that was a lot of money then.
That is a lot of money then, but still, compared to now, that's nothing.
But again, you could also buy a packaged home from Sears and Roebuck that you could obviously assemble for, a few $1,000s a home. So keep in mind that the perspectives haven't changed. A vehicle in the post-war period of time cost hundreds of dollars, not thousands of dollars. Again, and the same way that those vehicle costs went up, health expenditures doubled in the period of time after the war and through the 50s. And earnings, by the way, in the health industry doubled as well. And in 1950, now we're past the Depression era time, we spent 4.5% of GDP. Now, when we talk about increasing amounts of healthcare spending, realize that all wealthy societies spend more on healthcare, whether you're the ancient Greeks going to spas or whether you're people in this era of time. So in and of itself, more spending on healthcare isn't evil, but people have to realize the distortions of how we're allocating that versus housing or food or vehicles or other goods has been distorted by some of these good intentions, paving company type of decisions.
Yeah. And this goes back to a broader concept and a broader issue. I mean, Milton Friedman talked about this a little bit when he was talking about corporate taxes, and he said that all corporate taxes should be removed because they're just they're just an income tax that you don't realize, right? Because the corporate tax gets passed on to the consumers in the form of higher prices for their goods, but they don't realize it. And this is one of these elements of the healthcare market being warped, is that the further and further and further we get away from you going to see Doc Cunningham and paying him cash for a service and walking out, the further and further we get away from that, the further and further away we get it from a proper market forces that reduce prices and maintain quality. Because what I would say is this: we do have excellent quality overall of healthcare. Whether it's the best or it could be the best, that's a different story. But we do have overall excellent healthcare quality. But usually the market forces that would allow for us to maintain that quality, but allow for prices to decline, for example, where several doctors would maybe compete to be the best price for the best quality, a lot of those market forces just don't exist anymore.
Or convenience or other factors that people find valuable. In the post-war period of time was the first call in the United States for universal health care by President Harry Truman in 1948. It obviously went nowhere because it was loudly pilloried as socialized healthcare, because frankly it was. But that became common in other parts of post-war Europe for very simple reasons. Because the only entity that could build what now has become the British National Health Service was the British government. So when we sit there and compare, why don't we have a system like the British healthcare system? We were not a decimated economy as the British had to recover from after the World War, where the only entity that could conceivably do that was the government. And of course, they have their issues now. We can talk about that later when we try to come to solutions. But, every discussion on TV in England is about healthcare because every decision about healthcare is now a political decision. So in the same sense that you said, well, did we get good quality of care from Dr. Cunningham? We certainly did. And was it very personable? Was it very oriented? Yes, it was. And were we very satisfied with it? Was, yes. And he was an incredibly talented, comprehensive family physician.
Which, by the way, I think is what this is the other thing we were talking about the other day, and we'll talk back about this later as well. There is a reality to medicine, which is that certain things, and I would argue most things when it comes to medicine, are relatively straightforward, day-to-day, simple type of things that have relatively straightforward remedies. And in a world where you pay cash for the medical decisions that are happening, you have a higher investment in making sure that you really need that care. You really need that test. You really need that hospitalization, because there is a cost to doing so that you see that's immediate. And the cost when you don't see it and it isn't immediate still exists. And in many cases, I think is higher because you're not seeing it, and so you're not evaluating it. And you've had stories about this in the past where people have wanted tests because their insurance would cover it, even though you as the doctor sitting in the room did not find that test to be particularly necessary for the likely diagnosis that it was going to be.
I mean, an example, I would care for people with respiratory infections, and they would come in with a bad cough, a fever, and you would listen to their lungs with a stethoscope, 200-year-old device, by the way, and you would hear crackles clearly consistent with pneumonia. Maybe they even had risk factors. They were smokers or whatever. Not necessarily. But the point is that you would sit there and say, you have pneumonia, and say, well, how come you're not ordering a chest x-ray? Because I'm going to give you an antibiotic for this, and wouldn't make any difference what the x-ray showed. It may be important to know that it clears because I want to make sure there's nothing else hidden in there. That may be an important time. Or if you don't get better, then we certainly have to revise the diagnosis because I could be wrong. But the point is that I'm going to give you an antibiotic if the x-ray is clear, and I'm going to give you an antibiotic if the x-ray shows pneumonia because you're sick. But again, they would sit there and go, well, my insurance covers it. And I go, I know your insurance covers it. And I don't need to charge the extra $150 or whatever it might have been at that time for that x-ray. And they would look at me silly. Now, these are the same people who had a checkbook in their pocket to pay for the medicine I was going to write for, because they knew they had to pay for that at that time, because that wasn't necessarily covered at that point in my career at the pharmacy downstairs. And again, trying to work with people. This is a classic article. Again, my mentor, David Rubin, wrote it in the New England Journal of Medicine in, I think it was 78, on diagnostic nihilism, where you'd sit there and say, can I, through judgment, make a decision? Or is it a test that we're really after? We order tests that are sometimes very important, but if we don't link it to what we're going to do differently because of it, we're just spending money for no benefit.
Well, and you've talked about in the past a little bit about how, and that came out of the time that you were learning, and that how your education in the past, there was a certain focus on, is this necessary, and is this, a good decision to spend this money, where I think a lot of
value for care.
And I think a lot of the modern decision making for doctors, partially because of litigation, and I think that that's something we should definitely cover it a little bit, but partially because of the way that the testing industry has become so prevalent and powerful, that the idea that if I have, you have a disease, I'm 70% sure that it's this. If I had a test, I could be 90% sure it was this. But that extra 20% of confidence is probably not worth it. I should just treat it the way it is. Most doctors, I think, don't think like that anymore because they're not focused on reducing cost to the patient because they don't think about the cost of the patient.
So there was I know I'm not supposed to be looking at my in-basket today, but there was a result. A patient notified me in a voice message that they were concerned about this test result. So I look it up, and it shows that they have a finding in their abdomen that could be consistent with a significant disease. And the test was done looking for other things that thankfully they don't have, which is good. But the question was, does this person need to see the specialist for this? Now, this is a disease that normally causes weight loss and abdominal pain with any form of eating, right? And there are people that you know, that you grew up with, who've had it. So it's rare, but it exists. Well, this is an individual that we know well who does not have unexpected weight loss or pain with eating of anything. So you have to go back and say, well, a test result that indicates a possibility of this in the absence of any clinical symptoms justifies what for treatment?
Yeah, what are you solving by giving them treatment when they don't have any problems?
I'm not questioning the radiologist saying that this was a finding on a study. And I'm not saying it couldn't be important. But in the absence of clinical findings that support this being a problem to the patient, we are now looking at treating an imaging problem. We would call that an incidental oma, where you have to be careful because you can go on wild goose chases doing things to people that offers no good to them at all. And on the other hand, if you're more scurrious, you could sit there and scare people to death with these findings. In fact, one of the issues that we run into in trying to provide better value for care now is imaging findings that come back that are not well understood by whoever ordered the imaging. And of course, I tell my staff, don't order tests that you can't interpret, because you will often send some sort of harm in the patient's way. Not that you shouldn't use consultants or specialists when we need them, but the point is you have to pay attention, because you'll otherwise have, as we did in Wisconsin, the majority of our consults going to neurologists were for abnormal MRI findings that were of incidental nature and meant nothing to the patient. And yet people hang on these things. And yet we have to be careful of do they actually provide value? A good story, an injured high school football player, you know this family, had their first evaluation by the sideline athletic trainer who provided appropriate level of care. The young person was taken out of the football game and provided first aid and care, and they were seen by their physician in urgent care the next day. And the urgent care confirmed what the injury was, indicated 2 weeks of rest from football and a minor amount of care. That wasn't happy to the dad who wanted their son back in football the following Friday night. So they saw an orthopedic surgeon who then ordered x-rays, which told them nothing. And the orthopedic surgeon basically recapitulated the information of the athletic trainer and the urgent care facility, which was all our facility. And then the dad still wasn't happy. And so asking the orthopedic surgeon what else could be done, he said, well, I can send you to the sports medicine clinic at the university, but I don't think it'll change what happens. So they were given appropriate advice, but they still went, right? And they were able to be seen. That was wonderful access at the time. And they were given an MRI of this injured knee, and the injured knee said, you still need to be out of football for 2 weeks. And
just because we have better tests doesn't mean it changes the results.
And again, they had exams and appropriate attention and conversation, and that sometimes is helpful and important. But that's what we call flat of the curve medicine, because you went from sideline evaluation, which was actually accurate and paid for by the school who had the athletic trainer on the field for dealing with injuries, and I do that now. I'm not as good as the athletic trainer, but I can be there to help guide people if they need a broken bone assessed, or obviously when they need to be seen next by a specialist. But then obviously the cost essentially went up tenfold every step of the way, and there was no additional value of care. But
the results were the same.
But because the patient had insurance for this, by the way, which included all those steps in the pathway, and they saw none of that, the imaging costs were what people pay as a mortgage payment. Now, if you don't see that, can't weigh that as to whether it's worth it. It may be worth it to you.
And this is an important point, because I think sometimes when people contemplate the idea of healthcare costs, they contemplate them in a vacuum. And the point is this: we're not saying that you, with your current wage, should pay out of pocket, $250 or $2,000 or $10,000 for these things. What we're saying is, or at least the concept that we're discussing, is the idea that if you didn't have to pay health insurance costs and your employer instead gave the money they're spending on health insurance costs to you in the form of higher wages, and you paid cash for your services, either because you had an HSA, which functionally I think is a very good thing, or you just paid for it out of a savings account that you have, you would be a much better consumer in that you would pay much closer attention to the actual costs of things. People talk about our products all the time, and we make incredibly high quality, expensive leather goods, and they are expensive, right?
As you get the journal, I write in every day, right next to me.
Exactly, they are expensive goods. There's no two ways about it. But an MRI costs 10 times what one of our expensive products costs. But people don't. But people don't think about that, right? So when they get an MRI, it doesn't dawn on them that I'm spending enough to buy 10 of these great products.
Right. People ask me all the time they come in, let's say, with early back pain. Normally treated very conservatively under everybody's guidelines, and they'll say, "Aren't you going to get an MRI?" Now, I've learned in working with them not to diminish their concern, but to simply say an MRI for me is a pre-surgical decision tool. So if I think that you've not made progress or you have some evil red flag phenomena, I'm ordering that because I think you need surgery to your back. And they go, oh, okay, I'm good with starting with therapy or chiropractic or perhaps even medications in some circumstances, because we're going to look at this over a week or two at least. Most people's even more serious problems often improve with that care within that period of time. But we know that you're paying attention, and that if it doesn't improve, imaging may be appropriate and often necessary for making the next specialty decision. But again, that takes time to explain to people and to build their rapport, and that they are looking outside of your expertise for a confirmatory test, because in some ways they've been taught to expect that by everybody.
And that's part of the problem, is that to some extent it's partially because they're not, quote unquote, paying for it directly, right? At some level, if they were paying for that MRI themselves out of their pocket, out of cash, they might consider whether it's really worth it to do that. But because they're not really necessarily seeing that any or all of that cost, they don't evaluate it that way. And we evaluate everything that way, right? When you buy a car, how often do you buy a car and not consider the price? How often do you buy, a house and not consider the price, right? But oftentimes we buy, quote unquote, medical care, and we don't consider the cost. We don't consider the price.
But on the other hand, you don't want to necessarily, if I had a heart attack right now, be sitting there with your calculator in the ER while emergency care is being rendered to me to try to decide if I'm going to die in the next 30 minutes or I'm going to go to an expensive procedure. So we have to look at both sides of the equation. And
to your point, and this is true at some level, I do appreciate the fact that in this country, you cannot be denied care if you come to the ER and having a heart attack, whether you can pay or not, right?
Yes.
So that concept of we're going to treat you whether you can pay or not, I think is actually a vital part of the whole economic question.
That was part of the whole concept of the hospital as a
nonprofit,
as a not-for-profit, and many are arranged that way. Going further, the next biggest change in health insurance happened in the 1960s. And of course, under President Lyndon Johnson and the Great Society in 1965, Medicare was passed was added to Social Security to provide medical care to older people who were essentially otherwise uninsurable. They were over 65. They were often out of the workforce. So they, at that point in time, were otherwise left to pay costs, which, again, medical care had advanced in the 60s. We now had, bypass surgery to repair open arteries for people's heart attacks. We were beginning to see more advanced types of therapy for all kinds of things, including, breast cancer care, the earliest, organ transplants for heart and kidney, or then renal dialysis came to the fore in the 60s. Often, against significant resource limitations, there were boards to determine who would be qualified for renal dialysis. It was a scary time for a lot of people, because if you had renal failure and you weren't thought of as likely to benefit enough compared to others who were at risk, you didn't get renal dialysis.
Well, and so this is not just this is no longer just medical innovations that help everyone with their normal life from 10 years old to 50 years old. Now we're talking about procedures that would otherwise unnaturally extend people's lives because they would provide care for things that would kill people long before they reached 85, right? In that time. So now we're starting to move into the era of life extension as part of medical care, which to this point about
medical care is mostly about life extension.
Fair enough, right? Yeah.
I might keep you from dying.
Okay, fair enough. But I'm talking about unnatural, like longer life extension as far as the end of life goes, because a lot of people at the end of their life have a bunch of things go wrong all at once, right? It's not like, you have one thing that goes bad. All of a sudden you start to see multiple parts of your body start to fail. And this is where all of a sudden the rise of pharmaceuticals, I'd imagine, become a part of this in the 60s and 70s and 80s because advertising became available.
But drugs weren't advertised directly to consumers until much later. They were and always have been advertised to doctors. So a big part of what happened is that as medical care demand expanded, when you added in first people over 65 who might have had poor access before that and who used a lot of it because a lot of healthcare is used by older people. And then later when Medicaid was added to, again, deal with poor and often perhaps non-working people who needed access to medical care and prenatal care and things like that, you saw medical care costs double. And part of what happened was initial payment through Medicare was by what were called usual, customary, and reasonable. And that worked for a very brief period of time until the government realized that costs were exploding past anything they had imagined. And you could argue that the master of the Senate, the president of the United States at that point in time, had perhaps underestimated it. But needless to say, it's hard to estimate demand, as you would know in your own business. Then they essentially created price controls. So Medicare at that point said, we're not going to pay for that. We're going to pay a percentage or negotiated fees for various things. And then when certain things became to be harder to get, that then meant that some of those costs, because the market of Medicare and Medicaid was too large to be ignored, some of that then was shifted to private payers or commercial insured who, in essence, absorbed some of that cost.
So somebody like me, right, a healthy 30-year-old, soon to be 30-year-old, with no major prior conditions, and my wife, who is 27 with no major conditions, are all of a sudden paying a higher percentage of costs. We're paying more because
through a commercial insurer.
Somebody who is 85, 80, 78 years old is paying less because of the fact that Medicare is covering a less than a full amount of that, and that money has to come from somewhere.
And the hospitals were paying the nurses and keeping the lights on and making sure there were bandages downstairs and you didn't run out of IV fluid, and that's how they did it.
Well, and one of the challenges...
So again, that was, good intentions going perhaps wrong in the sense that distorted who then was paying for more and more cost.
And the more you distort the market, the more you distort who is paying for things, the harder and harder it becomes for the natural free market price controls via competition to affect the marketplace. And we haven't even gotten into how insurance discounting changed the retail prices, which we can get to that next. But one of the things that I think is important is because a lot of these advances were end-of-life care, they were an improvement in the capability of the system to keep people alive longer. Those people under the prior world, they just would have died. And obviously, as tragic as...
I'm getting a little more sensitive.
Yeah. And as tragic as that is that they would have died, right, the cost would have stopped at that point. Whereas now, Whereas now we're looking at a situation where we're going to extend your life by 10 years, 15 years via these procedures, but they're going to be an incredibly expensive 15 years. So now it's not just that we're extending people's lives and they need their normal medical care. We're extending people's lives and we're adding in a huge financial burden in addition because of that. Like I said, there's no moral downside per se to saying we're going to keep people alive longer. I don't think that's a bad thing to say that we're going to do that. But we have to realize that that comes at a cost. And the problem is that cost isn't being reflected by the individuals who are benefiting from it per se.
Right. So life expectancy in the early 70s was probably in the mid 70s, maybe 77. I could look it up. And we were spending 7.3% of GDP on healthcare at that point in time. Now, the political world, the business world was not standing still. In the early 1970s, Paul Elwood and others created the concept of health maintenance organizations in many parts of the country, but he was considered the father of a type of care where you paid a premium and that entity, often a vertically integrated system, like Dean Healthcare, where I worked for many years, would provide your needed care through what was then considered the term we use now is a narrow network, meaning you used their doctors, their hospitals, their specialists, and their plan of what they would use for various types of illnesses. Now, all those organizations had reinsurance if someone needed to go to a place like the Mayo Clinic for some highly specialized care, like a heart transplant. But they reinsured for that cost. And that became a legislated option required by employers who had essentially 25 or more employers during the Nixon administration. So as an example, perhaps one of the most famous is Kaiser Permanente, Kaiser Hospitals, Permanente Medical Group, then in California, now throughout the United States. And again, that was a legacy of the Kaiser shipbuilding empire throughout that period of time. And they were essentially then contracted groups where, let's say, maybe an HMO would contract if they were trying to expand into an area with a clinic in an area or a group of doctors in an area, and would provide pressure for people to go to their, hopefully, family physician, internist, or whatever, and get a referral if they needed subspecialty care. So primary care people became gatekeepers. And this was, in essence, a pejorative term because people didn't want to deal with gatekeepers. And this, in essence, was part of the backlash against this idea, was that people wanted to go directly to the dermatologist if they had a dermatology consideration, even if the family doctor probably could have managed it initially with very simple care. They thought, well, gee, I would rather go to the specialist if I have hypertension and see the cardiologist, although in most of my career, cardiologists never managed hypertension, right? But the perception was of increasing cost, increasing value. And as we became a wealthier society, that became the norm. And that whole concept of preventative care, of essentially, some sort of cost containment, was pushed aside within 20 years because people didn't want those restrictions, even if they had the opportunity to use a later term, bend the cost curve to make costs, again, paid through that third party cheaper, because again, you didn't see it all because your employer might have seen it. Again, this is when, Deere & Company was looking at, can we build a healthcare entity to serve our employees and their families cheaper than we can pay their insurance bills? And they were a big consumer of that. That's when those kind of things occurred. And again, there was the beginnings then of large-scale insurance consolidation across the United States when two insurance companies became one, called Cigna, as an example. And all of those things worked for a while. Until,
and this is where in-network versus out-of-network comes from, is the idea.
If you were an HMO customer, your care may be covered perhaps 100%, or maybe with some nominal copay, so you had some skin in the game. But if you went outside of that network, you may be paying for all of it and paying retail prices for all of it. And during that period of time, this is when there was additional governmental pressure to restrict the ability for hospitals to expand. Certificate of need laws, particularly in places like Illinois, meant that you couldn't build a hospital, right? Because the government began to realize that they were going to be paying a big part of that increased infrastructure.
So significant need, was it?
Certificate of need laws existed in many states to say you couldn't build a hospital without a legislative approval by a state, let's say like Illinois and Springfield. So you would have to make a case that you needed a hospital in a community.
So the government in that point would be restricting the supply of hospitals.
Exactly.
And for what purpose?
Because they knew they were going to have to pay for it.
Because they were going to have to pay for the capital expense.
Well, not necessarily that. Even if it was privately financed, they were going to end up paying a lot of the cost of the care provided in that facility. So the idea is we were going to restrict the number of beds, right? We were going to then restrict the number of things that were provided at a governmental level, even if, as an example, a community might need one.
Which, of course, goes directly opposed to free market principles. Because the idea is if if you have a larger, well, this goes back
but
to...
But you notice that this was not a free market.
I know, but my point is that if you're saying, okay, in a free market system that you want to see more supply inherently creates price pressures in a downward direction.
You would hope.
You would hope. And this is where that's an interesting kind of part where you see the market has warped so far at this point that we're already starting to see the ball roll down the hill towards markets that don't look anything like the free market.
But as an example, cataract operations in the 60s were major events of anesthetizing someone's eye in the hospital overnight, opening the eye capsule, took incredible skill, very hard work. Within a brief period of time, and one of my patients' work lives, by the way, an eye surgeon in New York City at his dentist's office realized that they were using this infinitesimal drill to drill and take care of his teeth. And dentists always had the best toys. And realized that they could do the same kind of thing, and they could drill into your eye and, in essence, emulsify, not remove chips, emulsify, take your whitened cataract that you can't see through anymore as you get older or exposed to sun or in rare cases due to disease, and remove that emulsified thing through this drill bit, and through the same hole insert a plastic lens that would allow you to see again, all in one measure. But the price of that surgery, going from a very complicated in-hospital overnight stay, lots of quiet so that you didn't disrupt the wound that was created to take the cataract out, didn't fall because it was a certain CPT code paid at a certain rate. Even though by the time your grandmother needed cataracts or I needed cataracts, they were a brief procedure with little risk using all these new tools. And I'm sure the new tools had costs associated with it and innovation by doctors who took risks to figure these things out. But the cost didn't go down because the governmental market wasn't prepared, or the insurance market was to say, we're not going to pay that for cataract operations anymore because you're not doing it in the same cost-intensive way as you did it when it was rare and there were more complications of it. So we didn't allow for innovation, partly because there was very little pressure for it, because vested interest groups, eye surgeons in this particular example, but it applies to all medical professions and imaging, etc. We're not interested in lowering the price that they got paid, even as technology improved, right? And that then faced the next major challenge to try to reduce costs, which were called diagnostic-related groups. So this is at the time I'm ending my business education in hospital administration, going back to medical education, where Medicare said, we're no longer paying you even on a reduced fee basis for all the things that you did for Mrs. So-and-so when she was in for heart failure or pneumonia or cancer. We're now going to pay you based on a diagnostic-related group. So as an example, pneumonia and the code you use for pneumonia got paid a set fee, no matter how long the person was in the hospital, no matter what you did. Now, there were outliers. If someone was, let's say, had complications, if they were there for a substantial period of time later, there were other workarounds for, as an example, when coronary stenting came into play, for the fact that that was a new technique with an incredible cost to these new devices that were put into coronary arteries to open blood flow from blocked arteries due to heart attacks or just bad angina. But again, that skewed how care was provided, because now all of a sudden hospitals had a vested interest, not only because their capital costs were high, to get people out of the hospital, but also to begin to pay attention to what did we spend to do things. But hospitals have always been in a technology war where you wanted people to come to you. You wanted doctors to admit their patients to you, so you had to have the best equipment, the most equipment. You didn't want to have a doctor who could do a procedure who didn't have the right tool in his hand. And so you were always buying and dealing with that type of stuff. But that work also then later fractioned care with hospitalists. So all of a sudden, I went from practicing for this 20-something years of my career as a comprehensivist, where I would take care of a patient showing up at the ER. I would get a call first and say, did I want to see them or did I want the hospital ER doctor to see them? And we had workable relationships with all these talented people. Or, as an example, I would care for people in the office and admit them to the hospital, care for them in the hospital, care for my partner's patients if they were away or on vacation, or just a night that I was on call and they were not. And obviously then their care after their hospitalization. I might not be the person who would assist in surgery like my partner did, who was in a very small community in Washington State. But, I did a lot of that type of care. I managed the ICU for a brief period of time. Hospitalists could get people out of the hospital about a half a day sooner because they would see them not only in the morning, but in the afternoon. And if they were hopefully better, they could send them home in the afternoon. Whereas I was going to see them the next day unless there was an emergency. And so they would stay. So now all of a sudden you've seen care fractured between a person caring for most of that person's care with specialty help to multiple people. And that's when, in large part, I became an outpatient internist, largely seeing only people in the outpatient setting and rarely now consulting in the hospital or providing social support to my patients in the hospital.
Is this when the concept of how important charting was?
Absolutely. Because as time went on, not only were you paid more if you coded, this is the term now, for all the complications, but 20 years later in the era that we're in now, where you're seeing insurance companies sending out people to people's houses to try to identify diagnoses that would essentially increase the rate of payment from payers because these people have more complications. Whether those complications have ever been treated or even considered in the care of someone. It may be important that if they have diabetes that you know about it. It may be important that you know that they have diabetes and they have kidney impairment. It may be important to know they have kidney impairment and diabetes and angina, blocked arteries to their heart. And that's relevant. But now, part of trying to improve reimbursement is to make sure we capture all of those things. Ideally, if we're using them to know that those are risks that we have to consider. But in some cases, some are being essentially rate increased because they've found that even if no one's taking that into consideration or providing any care for it. And that's the backlash that we're going to begin to see, where that potentially can be an area of concern for payers saying, well, does that really, the increased risk that this person is ostensibly having, is that going to show up in their care? Well, I don't know. We do know that certain diseases, diabetes is one of them, often then implicate later down the road costs of more likely to have heart problems or kidney problems, even under the best of care. And obviously we do want to pay attention to the best of care, but that's where coding and all of those ICD-9 codes and all those CPT codes that we talked about, now we have 70,000 of them. There's no way on earth anybody can keep track of them and the detail that's involved with them. But that's an important part of what we do now. And we always should have been paying attention to someone's risk factors. If they're a smoker, are they more likely to have lung cancer? Do we take a cough more seriously in someone at higher risk? Absolutely. That's what we're supposed to do. And also that involved us paying attention to people getting out of the hospital sooner and trying to avoid them coming back into the hospital for the same problem, because those readmissions within 30 days didn't get any reimbursement under the DRG system.
So the Medicare, so that does sound like, though, that there was somewhat of a market force involved in Medicare, and that because they only reimbursed you a specific amount, and because you didn't get the additional funding if they came back within 30 days, there was some market force to encourage hospitals to try to be more efficient in the way that people came in and got out.
Yes. And we've always wanted to do that. No one wants to have someone in the hospital and have them come back in the hospital in a brief period of time. Sometimes that happens for an unexpected event. Someone goes out and found that they had a stress ulcer, not noticed at the time of the hospital, and they come back in with a GI hemorrhage. That happens in the best of circumstances, but you want to minimize that. And we never expected it to be zero. Ideally, we'd like it to be less than 10%. Now, that also, because of these factors, began mergers of providers horizontally, if you want to think of it that way, where bigger equaled better, because you had better negotiating power with payers being insurance companies, who had to then seek provider networks for selling insurance in a given locale or where a business was located that they were courting to say, we would like to have your insurance business for your employees, whether it be a school district, a manufacturing facility, or something even like a government. So this turns into, there's a classic concept of Porter's 5 forces, which is obviously the power of the buyer, power of supplier, power of the market, and so on and so forth. But so you're saying that hospitals began to merge together
as units because
and doctor groups too.
Because they represented, when they're negotiating with the insurance companies, a larger group of people as potential places that employees of people, the consumers of the goods, would be able to go to. And so then when they went to the insurance company, the insurance company, if they want to take care of people in Des Moines, Iowa, they have to work with the hospitals in Des Moines, Iowa, right?
Yeah, because if you wanted to sell insurance to those companies, you had to have providers and hospitals that would work with you. And yet, on the other hand, you didn't want to pay retail, their charge master costs. You negotiated fees with them. And I did some of that work, very little of it, when I was in early in practice, where we were negotiating prices against our retail fees. And so what do? You say, okay, you would like a better deal. We will give you 30% off or 50% off. And that contractual adjustment will be reflected on a bill from us. So if a patient of that insurance saw a bill, it would reflect the retail price. There would be a component called the contractual adjustment. That was the discount that your insurer was able to negotiate with it, whether they're Blue Cross, Cigna, or anybody else. And then you might have your co-payment deductible and so forth as a part of that.
And so you see the hospital forming together to be able to have negotiating power with the insurance companies. The insurance companies have been grouping together for almost the same and essentially opposing reasons, is that they have more power when they're bargaining for discounts. And now all of a sudden you start to see that the insurance companies, to do business with these hospital groups, demand a very significant discount off retail prices, and the hospitals then raise the prices.
Absolutely.
So that in the end,
it's a very complicated game, if you will, of how can we increase our retail prices, then the increasing degrees of negotiations with and sometimes our own captured insurers. When we were involved in practice earlier, we were often at our own HMO was often our best payer, but still then we were still discounting our cost to our own payer that we owned 50%. And a recent experience in our own care was I got a comprehensive metabolic panel, a very common blood test that reflects kidney, liver type of tests, used to monitor high blood pressure or general health for a lot of things, including screening for diabetes and other things. And the retail price was $200. The contractual adjustment was $190.
Wow.
Meaning the cost that I was going to see and my insurer was going to see was $10. They paid $7, and they sent me a bill for $3.
Wow. So, I mean, and this is where we talk about some of these challenges with the market forces is, so because the hospitals are raising their retail rates in efforts to be able to maintain the bottom line number that they get paid regardless of who's paying it, and because insurers now are becoming the vast majority of people that are paying.
Absolutely. Or federal government through its Medicare
Medicaid
system.
Now all of a sudden, retail prices skyrocket because they're all made up anyway. And this is part of the issue, is that retail prices for hospitals, it's not like the Murdy Creative Company where we buy our raw leather from the local supplier and we have our people that we pay. And so our costs are relatively specific, and that creates a relatively stable product price for the market.
And perhaps you get a better discount the more leather you buy.
Of course, larger qualities,
stuff. But you make decisions about whether it's make.
And we pass that on to our customers, where if we've got customers who buy in large quantities, just like the insurance companies, to some extent we do offer them a bulk discount, right? So there is a certain
buy early for Christmas.
Exactly. Get your Christmas presents in and buy for everyone. Yeah. So you end up having the situation though where some similarities with traditional business practices come into play.
Of course.
But because the vast majority of people are these insurance companies, the retail prices begin to matter less and less, except for as vehicles to get the discounts to wherever the final price needs to be.
So if you are an uninsured person and you were having to face this market early on, now it's gotten slightly better, you were looking at retail prices for things, and they could be enormous. And perhaps you, if you knew ahead of time, could ask for charity care if that was appropriate, or a discount if you were paying cash, which has become more common, thankfully. And that is partly why medical debt is a major driver of bankruptcy in the United States. And again, a major push for reform, if you want to call it that, in this whole market. And it has also been a major push among everyone to say, I need work or another option that provides me insurance because I can't face this juggernaut alone.
Well, and one thing that I think is an important element of this is, for example, Leah and I are technically self-insured. We are technically an out-of-pocket payer. Yep. And so this has become an issue that I've become very passionate about and very engaged with because, for example, Leah and I were able to qualify this most recent time around with our local hospital for their financial aid program, which they have, which is if you're within a certain percentage of the poverty line, federal poverty line for your size family, you get a discount off your thing. Now, because we just recently had our additional child, we actually qualify for 75% off for the specific hospital we go to. Now, each hospital in the area is different discount prices, so we do shop around a little bit, but for us, it's 75% off. Before we had that child, it was 66% off, but that's only because we qualify from their financial aid program, right? And there are people who
So they are realizing that they're seeing more cash, if you will, sensitive, appropriately so, customers, and that's great. But, you know, one of your cousins took their child to an urgent care facility in an out-of-state location and thought it was great that they got a 90% discount off their $2,300 urgent care bill for a child with an earache.
See, so that's the way to do it. You charge them $10 million for the price, and you knock it off. You get them a 99% discount, and they're so happy to pay.
And they were very happy to do it that way because they said, "Oh, it only costs $200 or $225 for this visit," and they still had to go get the antibiotic at the pharmacy, as opposed to the ridiculous price that was being charged. And yet, they didn't have a primary care physician that they could have called on the phone and perhaps seen in the office, where that might have been a third of that.
Yeah.
A third of it. And again, that's where, you know, one of the things that I've been trying to struggle professionally from business school on is how do we create the best from the payer and the patient point of view, but also from the physician and extender position. How do we create the best system so that we can provide that care, access to that care at a lower cost, at acceptable quality, so that people aren't forced to go deal with the big black box ER setting, get ridiculous bills, have perhaps ridiculous setting. The ER is not an appropriate place for most diagnoses. It is too expensive. The liability, as you brought up earlier, costs of being wrong in that area is enormous. And so they will do a lot to avoid any risk of that. Whereas if you have a working relationship with a physician that you can talk to and you can iron out those details, you can get much better at lower cost care.
Well, and this is an issue that you bring up that's very important, though, because this is happening for you at the doctor level. And unfortunately, it has to happen to some extent at the doctor level. But for doctors to think of it like this and to act like this and to do this requires them to both be, in some regards, honest brokers and making an effort to improve not only the wellness of their patients, but the financial health of their patients. Mm-hmm. But it also requires them to be educated in how that's done. And I think you've talked about how a lot of times modern education for doctors doesn't really talk about how to do these things for cheaper because there's no incentive structure within the marketplace right now for doing them cheaper.
But this is the same time where healthcare costs have gone, like I said, from 7% to 22% of GDP, and wages to everybody is gone down because of that pressure of insurance costs. And when you're looking at it now, just to give you a personal thing, you know, the cost from my organization to me for health insurance, because they tell us that this is wise on their part, is something in the order of $25,000 a year is what the raw cost is for insurance through our own health plan, by the way. So we own these people. I mean the system, not these people. But the point is that, and we pay roughly a third of that premium out of my paycheck, all right? And we have substantial deductibles still. So if I was to have a major event, yes, the insurance cost would be $26,000, and so we would be capped. But I think out of pocket, we would still pay $15,000 or more
wow.
of our care. And yes, we do discount that. It's better for lower compensated employees in our organization because they want those people to work for us, and we need them to see that they're getting a very reasonable deal, although their health insurance costs are the same. And a lot of organizations do that. So you might have higher compensated employees paying more and lower compensated employees paying less. And that will ultimately be kind of how we get ourselves out of this problem. But those costs are enormous. I mean, I think it was your little brother who January something, we had not met our deductible, had a strep screen. Now your mother is 100% on diagnosis of strep.
Isn't the strep test like 40% accurate, which means you'd be better off taking whatever it says and doing the opposite?
It's a flipped coin.
Yeah, okay, good.
And many strep screens done with cultures give obviously perfect answers within a day, but your mother's 100% on day one. And so this cost, you guess what the strep screen cost at the pediatrician's office, by the way?
$40?
$250.
Wow.
That's the retail price of that strep screen. And your mother paid it. She was not happy about it because that was within our deductible. And the next step in the health insurance world is, okay, so DRGs didn't go well. Organizations are getting larger. So many organizations now, including the one I'm involved in, but even the ones I've been involved with before, are measured in how many billion. Wow. And anything less than 10 billion, you're kind of like small potatoes. And again, some of the largest ones are 120, 140 billion dollar a year companies.
Wow.
That operate in many, many, many states and in many, many, many doctors and many, many, many nurses and have very complicated relationships that then changed in the early 1990s with what ultimately became the next iteration of attempts for universal health care.
Well, this is also a big problem, though, just to stop there for a second on these billion dollar industries, is that organizations that are that large are fundamentally resistant to innovation in any form, partially because to implement innovation at that scale is incredibly difficult, very risky, and very expensive.
Yeah.
So to some extent, not only do you see the unification of a variety of otherwise competitive organizations that would have certain market forces to reduce their costs and certain market forces to provide more efficient care at better prices, despite the vast amount of market manipulation that already had existed at that point. Now you see a conglomeration. So now all of those would-be competitors are now part of the same system, and now they don't really function as competitors, even if they only pretend to be. And now all of a sudden you're getting into a situation where any real disruptive innovation to create an improvement is unlikely in the best of circumstances and impossible in a more realistic sense.
Machiavelli said that 500 years ago.
He's right. Yeah, he was right. I hate it when he's right.
The innovator has only woes ahead of him.
Yeah.
Because of the status quo.
Which is in part why
incumbent advantages.
Yeah. And one of the issues that we're going to, I'm sure, get to later in this when we talk about solutions, though, is that's where some of the disruptions in this market come from, places like Amazon, where they truly have nothing but enormous resources to try to solve this in their own way, which, like I said, they're not looking for necessarily a reduction in the overall. They're trying to provide better value because they want to get the big piece of the pie. And right now, to change this, you have to be very invested. It's a huge market to try to conquer because the players now and the system that supports the players is so entrenched and so ossified that, I mean, you got to be really dedicated and really creative to make a dent in it. But anyway, we'll get to that. So now we're in the 1990s.
So in the 1990s, President Bill Clinton, with his wife Hillary, were looking at what would have been a form of universalized healthcare within the United States and how to do it. And obviously a lot of the medical organizations, Hospital Association, American Medical Association, which I was a member at the time, and others, fought it because this was the first iteration of this since 1948 in Truman, and was loudly pillarized as this is going to be pilloried as this is going to be socialized healthcare. And in many ways, it was. Now, that they spent an enormous amount of time and effort trying to create it. But the problem with that point in time is that they didn't have the entrenched provider groups, insurance groups, pharma, etc., big employer groups, all on the same page. So it fell apart, and it didn't happen. Now, in 2003, an innovation that did happen was Part D of Medicare. So if you think about it, we talked about Blue Cross as hospital care, Blue Shield as payment for the surgeons who took care of you in the hospital. Then later we had Medicare, but Medicare didn't cover medication unless it was given as an infusion by a doctor, let's say like chemotherapy. So you were always, like early in my career, people were paying for medication out of pocket, so they were sensitive to the cost. Like I talked about the guy who comes in with a pneumonia and I don't do the x-ray. He has a checkbook in his pocket to go pay for
the medicine.
His medicine he's going to get at the pharmacy downstairs.
To some extent, that was a good market force in that there was a certain amount of, even if all of the hospital was expensive and there wasn't a market force to reduce it, even if the doctor was expensive, even if, to some extent, if you were going to be going on medication, there was an incentive to some extent to find the lowest cost solution to the problem.
But medications had become more effective, more expensive, more commonly used. A diabetic, maybe in that era of time, may have been on one or two older generation medicines. And then, and that's even become more complicated since, we're on more and more medicines that we knew would prevent the complications of their disease. And that's a really good thing. They would have less risk of hypertension leading to kidney failure, needing dialysis, and all those things that you pointed out are extraordinarily expensive. And so Medicare Part D coverage for medication was done not through the Social Security Medicare Administration, but through private organizations that people chose among a group of them. And they all had little differences about how they would cover this or that. And there was this great concern that this was going to, again, cost too much. But to my knowledge, it is the only federal government program that actually cost 40% less than what the Congressional Budget Office thought it was going to cover. Because old people, believe it or not, when it's their money paying those premiums for Medicare Part D, because they were, and knowing what they then were going to have to choose out of pocket, were making decisions of this plan worked better for them or that plan worked better for them based on what they were going to need. And the overall cost of the program both was a success for the patients, meaning older people, but also for the federal government that was obviously subsidizing part of it.
So what did Medicare Part D do, though? What was it?
It covered medication.
Got it.
So you signed up for Medicare A, hospital B, doctors. C existed for a brief period of time in the late 80s, which was catastrophic care. So that would cover catastrophic expenses. That got overturned again, and that was a complicated issue. And then now D, again, for medications, as that became a bigger part of medical care, was actually medicine costs. Now the next,
So the question though is did the Medicare D create an opportunity and incentive for generic drugs, for doctors to prescribe generic drugs, or
sure, because then patients saw that if they paid for, if a generic drug often would be 90 days for nothing, or 90 days for $5 or $10 delivered to their house, whereas a prescription medication, which is warranted in some cases as a brand, might be $70 a month, right? And the point of it is that, well, for some people, that was worth it to them. They got a better result from the brand drugs. They could make that judgment if it was worth it to them. And other times they were more commonly happy to say, no, I think the generic works fine. And in most cases it does.
Well, this is where for us, when we look at the pharmaceutical cost of this is part of the problem that goes on with this whole world of medicine, is that we've created an environment where it does get better. We have seen a significant improvement in the therapeutic drugs that we've got, in the therapeutic, just the generic therapies, as far as like physical therapy, occupational therapy, things like that are methodologies for improving our healthcare. We've got opportunities now in technology that improves and extends life in all sorts of amazing ways, like you talked about the cataracts. So we are seeing a progression of medicine. Yes,
my best friend in elementary school had type 1 diabetes, a terrible, significant illness. I was his guard when he was like giving himself his shots of insulin when we were on Cub Scout trips. Okay. But he died at 48 of complications of his disease. Now we have patients with type 1 diabetes identified as youths on insulin pumps with continuous glucose monitors who live normal lives and will probably die in their 70s like everybody else. But again, that's with daily expense of those levels of care and the newer medications that are out now, and some are even more expensive that are on the horizon for common care for those things.
So we are seeing an improvement.
When I was a teenager, acute myelogenous leukemia was a death sentence. The average life expectancy was less than a year and 90% died. Now, acute myelogenous leukemia, again, a common blood-borne cancer of teenagers and young adults, is 100% curable.
Wow. So we are seeing an improvement in our medicine. So it's not just that everything's getting more expensive, which it is, and that is a problem in and of itself. At the same time, we are seeing an improvement in the medicine. So it's not like we're getting nothing for this higher cost.
Here in Wisconsin, a pioneering critical care physician, backed up by a primary doctor who identified the likely cause, found a way to treat rabies.
Wow.
And the Milwaukee Protocol now is commonly used worldwide as a means of taking what otherwise, once it is established as a neurologic problem, which before was just death. And that particular
pretty bad death too, if I understand rabies death.
It's not a good thing. Was pilloried for why was he using up precious ICU resources to try an innovative therapy on this young woman who got bit by a bat in the back of church during the daytime. Bats are active in the daytime. Don't play with bats during the day. And her primary care doctor
don't play with bats in general.
Was a risk. Their local hospital didn't know what it was. The child was appropriately sent to the children's hospital. And this doctor was criticized for taking this person, providing a unique form of therapy, but a lot of intensive care unit resources, and helping this person recover not only in leaving the hospital, but joining him on the stage of a Heroes in Medicine event in Wisconsin where you could sit there and watch and say, this is a miracle walking in front of me. Now that type of thing has saved people with rabies worldwide. And it wasn't necessarily ridiculously new medicines or fancy. It was a doctor applying what they thought might work as a hero. That type of thing is happening, and we're seeing more and more of it. It is, however, not cheap. Now, the next big step in healthcare policy happened in 2012. We're on Christmas Eve by one vote, trying to get the legislators to the last minute before they all wanted to go home for a holiday. We passed the Affordable Care Act, otherwise called Obamacare. And the component of it is that they had learned from 20 years earlier with the efforts at what we then called Hillary Care, that they needed the buy-in of the AMA, the American Medical Association, the American Hospital Association, insurance groups. Most employers, big employers in particular, supported it. And it had, benefits of kind of like the perception of universal care, all right, where everyone would have insurance, again, through exchanges, but they also would have significant deductibles exposing them to retail prices for part of the initial care. This is how you got buy-in from providers and to a certain degree insurance carriers.
Because they knew they were going to get that guaranteed
that they
icing
were
on
going
the
to get
cake
some
for that.
money at retail prices, which is just like found money from God to them. And but they also would have less, or from a provider's point of view, less free care. We would do less care where we would got no reimbursement whatsoever. And again, we had famous quotes like, if you like your doctor, you can keep them, which may have sounded good at the time, but never was realistically going to happen when you had to have narrow networks to try to better control costs. And that the insurance company thought that they were going to have this big expansion in people forced to buy insurance who otherwise might not have.
Like people like me.
Or in small employers that could not offer health insurance.
Like me.
All right. And that they would go through exchanges and that they would be risked not in 5 or more risk groups where older people are at the highest risk and obviously the highest cost, and younger people, you and younger people even still, like your brother, who would essentially have hardly any healthcare costs because they don't get sick unless it's an accident. All right. That's what happened. But that also then increased the cost to younger, relatively healthy people of looking at an exchange unless they could get substantial discounts if their incomes were low enough, to the point where many young people dropped out of the insurance market and either became uninsured or, through a quirk of affordable care, were allowed to stay on their parents' insurance till age 26, whether they got married or not, by the way, or whether they worked or not, unless they were able to get health insurance at work, like your brother in Minnesota. So that's part of what happened. But it, in some ways, failed because the penalty for not buying health insurance was not high enough. It was clearly...
It was because it wasn't high enough because the cost of actually buying the insurance
was much higher.
Was much higher, right? At some level, and this is where it goes back to this concept.
It depends on whose viewpoint you have. So from the government's point of view, and as the system was meant to work, the penalty needed to be much higher to force people to buy insurance. But politically, it was untenable.
Because nobody wants to pay that.
a $2,000 or $3,000 penalty for not buying health insurance that was going to cost you $12,000 out of pocket, meaning $500 every 2 weeks out of your income, right? But there was, and has been modified over the subsequent 10 years or more, modifications that allowed for association insurance groups, for mutual aid insurance groups, like some of the ones where you pay a fee, but you're really transferring that money to somebody else who had a medical cost, and you're in essence sharing that risk.
Which is what Leah and I have been part of Samaritan's Ministries now for many years, and despite the things that I struggle with and I don't like as much about it, overall it has a lot of advantages. And just so those of you who don't know, Samaritan Ministry is a Christian organization where when Leah and I pay I think it's almost $700 now every month. So it has gone up. It used to be something like $400. So in the last 5 years, how old is James? Yeah, for 5-ish years has gone up to $700 from $435. The money that we send goes to another individual whose name we know, and they usually provide some basic information about what medical condition they're having a baby or whatever.
And hopefully you're all trying to get the best deal that you can.
And that's a big part of this is the idea is that, so when we walk into our provider, when we walk into the Marshfield Clinic, we say we are paying out of pocket and we are uninsured because our Samaritan's Ministry is not insurance, and they make that very clear in their documentation.
Right.
And
but you're sharing risk among others, like I said, those mutual aid associations long ago did.
Yes, and that it's a good program in that, for example, with the baby, otherwise we would have been out of pocket $25,000 was what it was quoted for Sabrina, and James was a cesarean, and that was $37,000, right?
Yep.
Now, obviously, that's a lot better than my dead wife and my dead child, right?
Absolutely.
So, at some level, I understand that some of this care that is given that is expensive is necessary for life-saving situations, and what's the value of that? It's hard.
Keep in mind that the healthcare system is probably happy, to live on a third to 45% of that retail price.
And so this is where
that's probably their break-even point.
And so this is where when you get this evaluation, part of the problem is that when we look at Samaritan's Ministries, right, and Leah and I have done this very intentionally. We actually aren't required by Samaritan's Ministries to do any of the financial aid stuff from Marshfield. I started doing it because I felt bad.
Well, you should.
I felt bad that it was costing us $27,000 when it didn't have to, because we could have gotten away paying $8,000 or $9,000.
Remember, the provider is also perfectly happy to do it too. You can walk into my organization and get, I believe, a 40% discount off the top of whatever the price is for paying cash. And some people do, and that's fine.
And that's a good thing to know. That's something that I think a lot of people don't really understand when they talk about the fear of being uninsured, right? Because this is another thing we talked about with Obamacare, was the fact is that if I had to buy insurance in the private market with Leah and I and our children, what I would want to buy, what I would probably buy, would be catastrophic insurance if we got in a car accident or if someone had cancer or something.
Well, and a lot of people use an HSA account, which is a tax-sheltered account, and that's another issue its own. And because of that, they pay those deductibles out of that account or other things like that. And then their insurance picks up things above it.
But that's my point, though, is knowing what I know now about the cost of medicals, especially with the discount that we get now because we qualify. And like I said, a lot of organizations, because of their charitable status, do have to, because of the reality of it, have to provide some measure of financial aid based on that.
They have responsibilities within our tax system to show that they are providing some degree of charitable care. So they're taking credit for some of that too, as demonstration of their charitable
of how nice we are
to avoid not paying taxes like every other provider. Now, the margin in the healthcare industry is probably a few percent to maybe 8%. Maybe in the best run for-profit systems, it may be 12%. Now, you compare that to other businesses, it's not exactly like they're falling over themselves in money, because healthcare components of healthcare costs, nursing costs have gone up substantially, particularly after COVID. They're all heroes. Obviously, the drugs that hospitals are buying often are in short supply, and they have to pay enormous amounts, or, as many health organizations now do, band together to make the drugs that they need, because no pharmaceutical companies will make them, or other kind of things like that. And, a scanner, a robot in surgery and all that, these are many millions of dollars for every piece of tool that you buy.
Well, and so in Obamacare, they made it so that, for example, like what I would buy, if I were to buy insurance in the traditional kind of sense, is I would buy catastrophic
and
care
self-insure
for the rest out of an HSA, because to some extent, and this is actually an interesting concept that when we talk about solutions, is if we had an HSA right now that was a $250,000 $8 HSA and it was invested in the market, that could probably, over the course of our life, cover almost all of the medical costs we'd have, even paying retail or some discounted form of retail. And we would never need...
But part of what happened with Obamacare, the Affordable Care Act, was that it made catastrophic insurance like that illegal. Again, to force more people into the exchanges. And you may remember when they launched the exchanges that they were, at least from a computer point of view, a fiasco.
Oh, yeah.
So there was lots of problems with that. And again, that made concierge care, where a lot of people say, I will pay a private doctor $1,500 a year for a physical, maybe some basic lab work will be thrown in. And whatever, if they get sick, they'll call me on the phone and I can get care, maybe even at home or clearly in his office.
Concierge care is the old version of medicine from the 1880s. But the doctor comes to your house in the school buggy.
In the same way, I may charge $300, $400 for an office visit. That same discounting that I applied to hospitals applies to my organization as well, where we would fall over in a dead faint if we got 30 or 40% of that. And of that, I might get half of that or less.
So it's not like and this is another element to some of this when we talk about cost issues where we see this ballooning.
I'm like other professionals, lawyers are in the same business.
Yeah, and to some extent this is the funny thing about health insurance is health insurance has taken loss leaders and flipped it on its head. It would make more sense to say that we're going to charge younger people less money because we're going to have them to pay us a long period of time rather than saying we're going to do this. I understand why they can't do it that way, but from a loss leader perspective, saying we're going to give our oldest patients are going to be paid the least amount of health costs.
That's because the government...
with the most costs they possibly have.
That's because the government has monopsonistic power to buy in the marketplace. And everybody else would like that same thing.
It'd be great when
it's hard for them to get it.
So now that we've got to create a problem, that the other issue that we've talked about a little bit, you and I, is how the rise in these enormous organizations also led to the rise of middle management and quality control elements where in a normal organization, there's a certain amount of market force via competition to say, how can I economize my labor force as much as possible to ensure that I don't have people in my organization that aren't generating value or that are costing a lot more than they're really bringing in. Whereas now that these organizations are billion dollar organizations, there's a lot of middle management cost that goes into those organizations that if they were smaller or broken up may not have been there. And so now we're seeing a cost rise, not just in equipment, like you talked about, not just in medicine costs, like you're seeing, but also in the fact that there's got to be a lot of people that are, in HR and payroll alone, there's got to be an army of people to manage that.
Well, and that's been echoed in the education environment and other places. There's an enormous number of people in my organization and most large organizations trying to identify ways that we can improve quality, even if it is just producing metrics that we then display to purchasers, whether they be a company seeking our health services or an insurer saying, we want to work with your network, saying that provides good care. But that made everything bigger. But again, what happened is that these things all failed their objectives. Again, we're back to good intentions, kind of didn't get where we wanted to go. And this effort to look at or overturn the Obamacare Affordable Care Act failed at the Supreme Court because Justice Roberts decided it was a tax, even though it was said not to be a tax. And ultimately it failed legislatively in 2017 or 18 when Speaker Ryan basically declared after he couldn't get the votes that this is now the law of the land, and it is the law of the land. Now, part of the next element in this is that Obamacare, the law of the land, did require these exchanges, these health insurers, to have a medical loss ratio of 85%.
What does that mean?
A medical loss ratio means that you spend 85% of what you take in on medical expenses.
So that caps their profitability.
You're paying, it capped administrative, marketing, and other expenses that were not considered. You paid for some element of medical care, a drug, a hospital, a doctor, a therapist, etc. Maybe initial rehab care for someone who was in rehab. Although, again, most custodial care and all that we call healthcare in the United States is not considered, which is why our gross domestic product component of healthcare is higher than other countries, is they don't consider custodial care as healthcare.
Custodial care is?
Someone in assisted living, someone who's has to stay at a nursing home because they have no other place to go and get. Which
is an enormous expense, right? I'd imagine that's a huge part of it.
It is a lot. All right. So pharmacies, health insurance then vertically integrated with what we then had as pharmacy benefit managers, which now control 70 to 80% of all the drugs used in the system. Now, smartly on their part, pharmacy benefit manager profits their costs are considered medical loss. Their profits are outside of that. So if you were vertically integrated with it, if you were a big health insurer and you owned Express Scripts, let's say, Express Scripts profits rolled up to your consolidated
organization
balance sheet, but it was not, you were still within the law. And so now the same price escalation that we saw in medical care by hospitals and doctors is happening in the drug world, where all of a sudden certain medicines for weight loss or diabetes, that example, are $1,000 or more a month. Good ones too that work well. But on the other hand, the pharmaceutical company is now contracting with pharmacy benefit managers, which represent enormous buying power for their organization and the people who depend upon them, and getting enormous discounts off those retail prices, unless you're the one paying those retail prices. And then obviously charging you maybe $100, they're getting a discounted price of, let's say, $300 or $400 for a $1,000 a month drug, and hence creating a profit stream that is outside of HCA limitations. So that's, again, part of how
a downstream effect of good intentions that
downstream effects of good intentions didn't necessarily mean that costs were going to be kept lower. And that's where, again, when we are farther and farther removed from that, we end up in more trouble.
Well, and this goes back to the kind of the fundamental concept, the fundamental premise, and functionally one of the elements that I think is part of the solution discussion is this idea that if we're not saying to someone that if you still were paying what you were paying for health insurance and your employer was still paying what they were paying for health insurance, and then you had to go pay retail prices for your local hospital, that would, out of pocket in cash, that would be the best solution. That's not a good solution either. The idea would be that if the retail prices of your hospital were actually reflecting a more realistic price based off of competitive forces in the marketplace, because you could go get your knee surgery at this hospital or at this hospital, and so now all of a sudden you compare the cost and benefit of each of those hospitals at a very reasonable market rate that was an appropriate market rate for what it is, not warped by the insurance discount system. And you saw that $12,000, $15,000, $20,000 of additional paycheck was given to you every year. Now all of a sudden, that looks a lot more like...
Or your business didn't go out of business. Or you lose your manufacturing job.
All of those things start to look more like what a normal free market solution healthcare system would look like.
So on cost savings, in the last 10 or more years, you've seen a new emphasis by some employers to do what we call direct contracting. And it's a common thing in this particular locale. You were actually at Health Summit where this was primarily discussed, where a big company might say, we have a bunch of employees. They're going to need knee replacements or hip replacements as they get older, or they're considered a retiree for us. And so we're going to directly contract with Orthopedic Hospital of Wisconsin as an example. And that organization is going to give us, I don't know what the current price is, I'm making this up, $15,000 soup to nuts for a knee replacement, guaranteed. Meaning something goes wrong, it's still covered. You don't pay more than the $15,000. Or maybe a hip for $27,000 or whatever it happened to be. And what happens is that they create benefit design efforts, which have always been in part of this, to say, if you're living in that part of Wisconsin where that's reasonable, and you go out of your way to go to that particular provider, we will cover your joint replacement with no out-of-pocket cost.
So there's a market incentive by the employer to the employee.
And the employee says, if I go to that provider and I get my hip replaced done, and it's good service and good quality, that's not a question. I can get it done and it doesn't cost me out of pocket. Whereas if I go to someplace else that maybe my network says is a network provider, but costs $60,000 for that hip replacement, I'm going to pay $6,000 in cash out of my pocket, maybe my HSA, for that service. And so all of a sudden you're seeing some steered care for those unique, often one-time kind of things. It's harder to do that for my heart attack.
Yeah.
But there were health insurers 40 years ago that were saying, I'll put you on a jet and your wife and fly you to Houston to have your bypass surgery done at the heart hospital in Houston, because they would do it for soup to nuts at that because they were really good. They were pioneers in this, and they also wanted the volume.
Yeah.
And again, a lot of places that offered high levels of volume could do things at a lower cost because they got better at it. So that was one part of it. The next legislative effort to try to, again, improve this, again, in the latter half of the last decade, was efforts to legislate price transparency. So as an example, you go to a provider, they're by law obligated to give you an estimate of costs. Now, those costs, by the way, are their retail prices.
And Leah and I get those letters regularly because we just had a baby, and so some of those things are predictable.
And that's fine. But what was really hoped for and never truly happened was to be able to look at what those providers get reimbursed by health insurers for that variety of services, because that is considered highly proprietary information. So the emphasis was...
you mean that the insurers don't want to let everyone know that they're not nearly paying very much for this thing and you're paying an enormous amount? Who could possibly believe
getting
it?
better deals, or all those kind of things, so that you could decide and use that information as a consumer or potentially a business buying insurance for your employees or their retirees. So again, that never kind of went fully across, just like electronic medical records were supposed to be interchangeable, where if you were in one hospital, it used one system, and you went to another hospital, they would be able to show it. That never quite
materialized,
because again, these systems were too proprietary. There was too much lobbying to stop it. And again, the most recent is that even in the most current administration is now they're saying where we weren't going to negotiate prices under the 2012 Obamacare, now we're going to go after the 25 highest in total dollar volume expenses of medicines for, let's say, Medicare or Medicaid, and we're going to negotiate prices. So again, pharmaceutical realizes that they're saying, okay, we're not going to be able to charge as much for insulin, as an example. It used to be $35 a vial, and now is 8 times that. But we'll go along and sell it for $35, and knowing that this, again, is cost shifting, they'll make it up someplace else, or there will simply be fewer drugs developed because it now costs $1 billion to get a drug to market that has any likelihood of success. There are a few orphan drugs that are given special exemptions for these things, because you may develop 8 or 10 drugs to get one that actually works. And gets through the regulatory process. And you had to go through a lot of effort and research and money to develop that. And you may have a relatively short patent life where you get to be the exclusive maker and seller of that product before it's open to generic competition, because you had to patent that chemical long before it got to the day that you could actually sell it. So that's how we got to this paved road to hell, if you want to think of it, which has, again, if you think about it, all of these things explain in part how we got to the system that we're at. And what do we do to essentially make it more sensible for people, comparing this to, can I buy a house? Can I afford a second car? Can I afford to send my children to a parochial or private education? Can I afford a vacation home somewhere else, or help cover costs of elderly parents, or other things that people have to make choices over? Can the government similarly say, how do we get out of the fact that an increasing component of many state budgets is no longer higher education or roads? It's healthcare costs, either through Medicaid and the expansion that happened under Obamacare, or other kinds of things, because they have to decide whether we're going to have a bigger military to provide support, or other kinds of things that we might like to have. And that's where you have to say, well, the only way to do this, and this is completely speculative on my part, I will not pretend to be an expert at it, but I have been paying attention for a long time, is you have to unwind some of these changes that have occurred.
Well, and to put a point on this, being a doctor is a highly skilled, licensed profession, but it's not unique in that there are CPAs and attorneys who are also highly educated, licensed individuals whose businesses are services.
And have responsibilities to greater society as well, because you count on accountants to provide accurate information if you're investing money.
Yes.
Or you're a bank loaning money to a business, or if you're a lawyer, they have responsibilities to the court.
So this is where it's not like we don't have
legitimate fact.
It's not like we don't have what I would describe as modern day equivalents of what medicine could look like if it wasn't such a warped and divided market.
And in some ways, when people talk about the free market, free implies that there's no cost. Markets always have costs. The issue with open markets is that you know what you're getting and you decided it was valuable to you. Whether you're buying a Chevy and that's the best car for you, or you want to buy a Cadillac.
Well, I think people are talking about free markets. They mean like free in that it's a free association. You're not required, which, like I said, part of the challenge that we're dealing with in some of these cards is it's not insurance. That's not the right way to think about it, because you're relying on using it. To the degree in which you use it, that's somewhat up to debate and somewhat up to insurance.
And may be unpredictable and may in some ways be insurable. But what people don't want, and to a certain degree, I don't want patients, when I'm talking to them about a serious medical consideration, I don't want them sitting there thinking only, what is this going to cost? They may have other factors. Yesterday, I spoke to a person whose test exam showed that they probably have a serious form of cancer. And they had talked to their family that if this showed up on this scan, that they didn't want treatment. Now, I told that person that I would take care of them anyway, and I will. But, the dilemma is that I want them to think about it. I want them to understand, here's what the types of therapy, how we would get a best diagnosis, how do we do that economically, what is the appropriate treatments. There's fairly straightforward treatments for it. And likely in that particular case, it would extend their life a few years. Now, that cost trade-off shouldn't be the first thing they consider. They might want to consider, well, if the treatment is too burdensome, I don't want to do it anyway. And I believe that's what that individual will say. And that's up to them to decide, right? But what a lot of people want is they want to essentially say, I'd like healthcare and I don't want to pay anything at the time of service. Now, the perception in the mind of people is that then it's free. Now, free things are almost always oversubscribed, right? So if you think you can get free clothes, you'll buy more clothes. You'll get more clothes. Or free cars, we get more cars, which was part of even my dissertation paper many years ago by the leaders of the County Medical Society dealing with this issue with Deere and Company, was how do we change this back so people see something about it?
That's the issue, though. I mean, we talk about economics. Fundamentally, an economical question is always a question of limited resources and how to allot them best. And the problem is that the further and further and further away you get from paying for something, it doesn't cost anything different. You just don't know how to evaluate its cost properly. So while I agree with you that fundamentally we don't want the first thought of anybody getting medical care to be, how am I going to pay for this? It certainly should be part of the equation, because the point is, you're right. People would take infinite medical care to extend their life ad infinitum. Now, there are some people out there that say, and they should. There are some people out there that believe that everything should just be free and you should get whatever you want because somebody else should always pay for it. But that's not realistic.
Well, I mean, again, there are right now, again, an effort of saying, how do we provide universal health care? One of the arguments that has been around now for a number of years is that we would have Medicare for all. Medicare for all, if you sat there and said, would probably increase costs to everybody through taxes, direct taxation of probably 10 to 15% of their current wage base. And you might say, well, gee, I'm already paying that in healthcare premiums, so maybe it's a wash to me. Okay, that sounds good. But Medicare reimbursements to providers, if that remained where it's at, would take many providers, particularly in smaller communities, and there would be no smaller hospitals because they could not afford to operate and hire the nurses, attract the doctors, pay for the supplies that they need at the current cost of the market. You might say, well, maybe innovation would come in, and we can talk about innovation, and probably it will help. But, the hospital that I practice with in Wisconsin, and probably, frankly, the one that I practice at now, couldn't survive on Medicare for all payments. It would close. Now, what does that do? Now, you might say, well, that's cheaper. We have fewer hospitals, and we do have fewer hospitals now than we did before. And some of them are in communities that have shrunken populations, so some of that's just natural. But what is the cost to you if instead of driving to the local hospital to deliver a child, you have to go an hour away, or in many cases, many hours away to get access to medical care? Those are costs that aren't seen by government, maybe by taxpayers, but they become costs imposed upon you. And take my word for it, in most systems that have that type of care, I'll use the British health system as an example. You have lines, you have queues, and certain things are just simply not covered. An example I made was a patient of mine who was contracted COVID, was in a hot hotel in Scotland. And because he knew we talked about this, and I thought at the time it was available, asked the National Health Service, because that's who he gets health care from in Scotland, can he get Paxlovid? He said they don't provide Paxlovid in the UK, at least in that circumstance. And so he was told with his fevers, chills, and shortness of breath, and he's in his 70s, to take ibuprofen and hope for the best. Okay. Well, thankfully he got better and was able to come home. Now I tell people to get Paxlovid to take them if they're going to out of the way places where they might have access to care, and to self-test so that they can obviously, hopefully, do better if they're at high risk.
And you deal with mostly older patients, so it's because
I do. My average patient is over 75. And again, efforts for universal health care have been put forward, last in California, previously to that in Colorado, and also in Vermont, and were rejected in legislative efforts because of the cost of taxes that were estimated. Now, again, governmental estimates of what tax burdens for certain services are,
they're almost never right.
may not be correct. And obviously we see in the British press where discussions about how to improve service within the National Health Service, how to reduce waiting times for joint replacements, which is true also of Canada, and where many people seek care in Detroit and in Boston because they can escape that system. They buy private insurance in Canada that allows them to get out of those health systems. Well, in many ways, we are the last source of the highest quality of medical care in the world. We have people who fly from all over the world to get medical care at places like the Mayo Clinic and the Cleveland Clinic and other similar places. And so you at some point or other have to go, well, this may not be all what it's cracked up to be. Do you want healthcare decisions as practical as will your doctor see you to become political decisions? Where again,
because everything is so comfortably calm in political situations.
But they're also weighed against other political needs. How much do we pay firefighters? How fast is our fire department going to respond if we have a fire? These are all costs that are realistic costs that politicians have to make decisions about. Do we want, more soldiers or less soldiers? And so to a certain degree, we have to understand that
when you wrap the medical costs into that decision-making structure, it's competing with those things for those dollars.
And again, part of what you want to do is the concept of subsidiarity. Do you want those decisions to be made as lower down the system, closer to where the true implications are, which may be your family, your pocketbook,
your doctor,
and them working in your best interest, which may include your best financial interests for you and your family? Or do you want them made somewhere else up the line?
Well, and this goes back.
How do you get there? Okay, so part of it is we have to essentially try to break the demand for expensive health insurance that has been baked into the system. And again, all through good intentions. No one did this thinking this was bad. Wartime decisions, things that really at some point needed to be done. But as an example, one of the first things that would probably be needed and has been proposed, but again, any form of entitlement restriction becomes controversial, as you can imagine. What is the longest lasting thing? A governmental program. Okay.
The only immortal thing.
Perhaps. Is to reduce the tax deductibility of health insurance. And again, that was when we were going to tax Cadillac care. That was part of the ACA. That got wiped out pretty quickly. Because the idea that people with high costs, we're going to see that become tax limited and you're going to be paying for more health insurance costs was anathema to many people voting for politicians.
Removing that tax, and this is where at some level the conservatives and the libertarians end up agreeing with the Democrats on kind of opposite ideological spectrums, which is that the Democrats want to make it taxable to some extent to raise tax revenues.
$300 billion a year.
And so they want to raise the tax, they want the tax revenues, and the conservatives and the libertarians think it's a good idea because they think that it will reduce the amount of cost because the taxes inherently disincentivize it to some extent. It creates a reason to not do it. However,
or it puts it in the position where you're making those choices against other goods in life.
Correct. Other similar, you have them on the same playing field, especially as an employer.
But again, there's many organizations, healthcare organizations, including some of the ones that I belong to, that say healthcare is a right. Okay, I certainly want people to have good healthcare, but I'd also like them to have housing, food, and in most circumstances, adequate transportation. I'd like them to have, free and access to communication, education, libraries as an example. And some of those were produced by charities. The Carnegie Library System, as an example, was charity libraries built throughout the United States by
beautiful ones too.
Andrew Carnegie, by the way, who made a lot of money and mostly gave it all away, right? But he was a robber baron too, right? Now, granted, you get to enjoy steel because of Andrew Carnegie as well. No, so that's one. And that would not happen. I don't think anybody's proposed that this is going to happen overnight. But the idea is that you would say over maybe a generation, 10 years, 20 years, that you would reduce that tax liability and then hence slowly put more price pressure through negotiations, labor negotiations or others to say, do I want more health insurance? Maybe if you knew that more of it was going to come out of your pocket, you would work with your employer to say, let's not pay that much. Now, that's the next that you would need, is you would need a variety of health insurance options that fit people's needs, which may be, let's say for you, catastrophic insurance, like you said earlier, where if, God forbid, you were in a terrible accident or had a terribly unusual illness strike you or your family, you would have maybe the first $10,000, maybe even $20,000. Maybe you have to borrow money for that first $20,000 the cost, but the costs above it
are covered.
For a bone marrow transplant for a child who has a leukemia would be covered. And you would say, okay, that's a lot of money, but I'm not paying all of it. And I can maybe deal with a once in a lifetime expense like that. But again, that means that you have to be a shopper for insurance. You have to know the implications. It'd be like if you buy life insurance, is normally not the best example, but maybe car insurance is from a really reputable car insurance company. They really pretty reliably pay claims and they're pretty good about it. And they're pretty honest and upfront about it. And we've had good success with ours. Maybe if you're buying insurance from a lower rated insurance agency, they're all regulated by the state insurance boards, but maybe you have a harder time getting your claim paid. And you weigh that decision when you're buying auto insurance to say, well, I'd rather buy it from this more reputable company because I know I'm paying a little bit more for it, but I know they're going to pay my claim because I cannot deal with the loss of thinking I'm insured and finding out that no, I'm really not.
So that's a balancing act, though, because, and I think that that's an important point, though, and I think there is a way to do it, which is to split, to divest regular care from crisis care. Because, and I think that's a really important step for most people, because it allows for innovation in regular care,
right?
Which is an area of high volume. Regular care is an enormous amount of the care that is needed in any system.
And then you would see more care at a primary care level be direct pay, which we call concierge care, but it's direct pay. Your aunt, by the way, is struggling with this issue now, where the one doctor she had was out for a bit of time and came back and said she was a concierge doctor and she'd be happy to see her for $1,700 a year. And that was not affordable by your aunt. And so her next doctor said, well, he was going to go concierge care, but I think he was going to take insurance, but he still needed $350. So you will see modifications of that marketplace that will provide people care. And in some of those type of situations, your doctor takes care of you on nights and weekends, and your doctor sees you in the hospital, et cetera. Now, granted, how that works for the doctor is a different thing, but they might only have 400 people that they have to take care of, because if you add 400 times 1,500 people,
that's good money.
That's not a bad chunk of change. And if you don't necessarily have to have an office because you're going to people's homes again, and you don't need a lot of equipment again, right? Maybe that actually makes it all sensible, that even if you have answering services, and obviously there's always administrative costs.
Well,
you'll see more of those kind of things. And you brought up something the other day, is you will see more people seeking what I'm going to refer to as almost self-care, and self-care through better tools. We've always had family health manuals, whether that be for pediatrics or the Mayo Health Clinic guide, where you could look up at home and say, does this rash deserve medical attention, or is this something that I could try these basic first aid things that you could go get at the pharmacy?
Like the WebMD is a classic example of self-care, where you go look up your symptoms and it tells you, right?
Almost all my patients do.
And we've talked, it's dangerous to do that because it's always cancer. Now, one thing...
And that's sometimes a problem, is that people misunderstand the prevalence of their disease, of a serious problem like that, amongst the fact that that's not very common. It may need to be considered. And I'm not saying it's never seen, but it's not the first thing that actually...
Well, and we talked about this yesterday, is that the rise of dedicated AI, like I said, I think general AI is not going to be able to do medicine as well as perhaps a dedicated AI that was trained on medical records, that was trained like a doctor, that has access to enormous amounts of data. That may be able to improve some of that self-care regimen, because it can absolutely be able to answer questions that you don't need to see a doctor for, but you don't know how to answer yourself.
So a lot of care, like for a lot of medical conditions, I'll use an example. Let's say hypothyroidism. A syndrome in which, for a lot of people, more women than men, their thyroid gland ceases to work and they end up with sluggishness and a number of symptoms. And if they take thyroid medicine, they feel better, their symptoms go away. And common medical care is to see that person once a year and to order labs to assure that they're safe and appropriate. Now, that's an example of a care that probably could be managed by AI, where yes, you do need to go in and answer and ask questions and think about, do I have this or that symptom, both of too much or too little care? See if my labs were safe before. Has anything else changed with my other medications or my diet that could influence how it's working? And make a decision. Do I need additional labs or can I just have AI refill that person's medication with a pretty high confidence that nothing is going to go wrong? And you will see more of that innovation creep in, particularly when the customer demands it and the safety is there and the research that backs it up. And you'll see when many of these things are decoupled from tax advantage insurance, that people will look for innovative access to levels of care, whether it be highly subspecialized care, neurology, or as an example, their basic primary care doctor, who then only has 400 people to pay attention to and who could be interacting them with on their phone, like I've been doing even while we've been talking.
Well, this is an area at some level where you can see, for example, Amazon's been trying to do some innovation with their healthcare stuff with their Amazon Pharmacy, and I have no doubt that the rise of telemedicine, in part because of COVID, led to, and traveling nurses, for example, like the one that came to my house to do blood work for when I got my health insurance, my life insurance. Yep.
She wasn't working for you.
I know. She was working for the insurance company. But my point was that those people, plus telemedicine, plus Amazon's pharmacy program, which I'm sure they're just buying pharmacy production facilities, allows for them to offer somewhat of that non-emergency, non-crisis care, some of that regular care at a relatively high level for a much less expensive
cost. And again, for a lot of routine things, does this picture of this rash, this eye issue require X? It may be very appropriate levels of basic primary care, and that will put a lot of pressure on what I'm going to refer to as algorithmically trained, guideline-directed medical therapy primary care people to realize that they now have been replaced by AI. Radiology is likely to be replaced by AI soon because X-rays can be read by machines almost as
very
good,
well, yeah,
almost as good as radiologists. Now, my radiologists that I interact with regularly are wonderful people who often guide us as to what do we think of this and what do we do. So they are often helping with providing interpretation well beyond what their report says. Bless their hearts. And we'll see as people can use money out of their pocket to provide the services that they find important, perhaps backstopped against some form of catastrophic social insurance. Because again, healthcare is a good.
Yeah.
Is it a prior good beyond all other goods? No. Is health wealth? Yes, that's an old motto. Is it something that we all should seek? Yes. But we all have to be kept warm, fed, and housed as well. And I don't think that if we unwind some of these paved with good intentions efforts, we will get back to people where we can get adequate health care with adequate safety nets so that, the poor and those who are of lesser means are cared for. Because that is, again, back to the Christian basis of medical care. We will get back to that. We aren't here to leave babies and orphans out in the cold anymore.
Well, and for us, obviously, Leah and I have evaluated this for our own sake, and we're looking right now to downgrade from the Samaritan Ministry Plus version we're on, which is 100% coverage, basically, after a $400 upfront fee that we pay every time. So it's not like for every instance, we pay a $400 fee, regardless of, there is no deductible per se, but that's designed to prevent people from abusing it per se. But we're looking to downgrade from that, which is, like I said, almost $700 a month, down to the 90% version of it, which covers 90% after $1,500 every time.
Yeah. And what's that cost?
And that costs $400. And we're going to take the difference of what we're currently spending and putting it in HSA.
And that's a wise thing for a lot of people.
Because the point is this, and this is something I go back to at some level.
And HSAs, remember, are still tax-advantaged accounts.
If we could get to the point, though, where our HSA has $250,000 in it, that would be incredible if we could pull that off. But if we could pull that off,
most people will never achieve anything like that.
Of course, but if we could
even your brother,
pull that
who's
off,
been very good at it,
yes, he has,
doesn't have anywhere near that kind of number, even with the fact that it's growing through investments.
That's the point.
He has essentially saved that money and can use it later, plus the investment gains for healthcare purchases.
This is my point, though. With an HSA, it is invested in the marketplace. So there's a certain amount of advantage where you say, okay, the market every 10 years on average doubles your money, right? 7% is the regular interest or regular return rate on the market if it's invested. So the point is this, is if you say, okay, if you're young and you build up an HSA basis, and you can build up that HSA basis, and it's invested in the marketplace, but it could theoretically cover all your costs. Well, that's true. That does create its own problem. But you create an environment, though, where it creates its own return on investment that later in life could be millions of dollars.
But that's true of saving for cars or other kind of things. So again, it puts it back into the prospect where it's like anything else. Now, other things that would probably benefit from this is for people to look at quality measures that are more what I'm going to refer to as patient-centric. Access, affability, practicality of and ease of making sense of what I need to do versus what I'm going to refer to as quality metric emphasis, where we're saying, what's our mammogram rate? Or how many of our patients got colorectal cancer screening? And I'm not saying either of those are bad measures, but right now, many measures are based on claims paid, and that's what they're measuring as, did that really help lower colon cancer risk? Well, that's a little bit obscure. It's not as clear cut as you going to your provider and you being happy with the advice you got, the medicine worked, you felt you got a fair care for a fair price, and that you find the medicine to work, or if you have a problem with it, you get an answer. Now, liability costs have been largely legislated to provide reduction in what we used to call pain and suffering, to cap that, because liability costs for some specialties like neurosurgery could be $300,000 a year. Now, take my word for it, the neurosurgeons are not poor. But that was a barrier for many people to enter into that kind of field because they can't afford those kind of costs. Or communities couldn't get access to that kind of care because no one would work in those communities. Now, for a lot of people, if you provide good communication skills to people, you don't bear substantial primary care costs, or for like primary care malpractice. Last time I knew mine was probably less than $6,000 or $10,000 a year out of a couple $1 million of things I generate in direct services. And more importantly, their downstream imaging, hospitalization, referrals, and so forth.
So the out of the revenue that you generate for the hospital.
If you think of all of it,
if you would think of it as you as a business entity.
Right. This is the most expensive tool in medicine is my pen. Because if I write, go see so-and-so is going to do this test and that test and this test and this test, and he's going to spend $10,000. And if I'm not paying attention, I can do that all day long.
Yeah.
And maybe that's absolutely necessary, but there needs to be judgment as to whether that needs to be done.
Well, and we haven't even really, and I don't think we have time for, unfortunately, this time around, but we haven't really even covered about how insurance as entities are taking an enormous amount of profit out of these systems.
They have investors too. When we were developing a physician-directed health insurance, we had to take stream of revenue out of our what would have been paychecks or equipment we could have bought or buildings we could have built or expanded and put it into reserves to cover healthcare costs. So we had to take that money out. So if you're an HMO, if you're in health insurance, you have to have reserves. Maybe it's a fancy building, right, that you cut your name on, but it's still an asset that is the backup, the claims that are out there that could have come against you. Just life insurers do the same thing.
But that also allows for a situation.
Obviously, somebody had to invest that money. Some older person took their life savings and put it in that company, and they want 4% of their revenue so that they can buy groceries.
Well, and so then you've got the beyond, and additional, we haven't even really touched very much on the judicial aspect of this, about how medical malpractice claims going in favor of the patient, which, like I said, is probably a good.
Very few of them actually come to judgments by juries because most are settled out of court, and that's appropriate. And we have, in many states, this one, and I participated in it, arbitration, where there's a negotiated issue where a medical expert, I've been one at one time, a couple times, where you render an opinion to both sides of the case and say, based on what I know of what you've told me, this is going to be X, Y, or Z. And they get to decide what they do after that point. People can still pursue their case, or they can decide it's probably better in their interest to settle. Fine, that's appropriate. That's how the market works. That's how losses should be done. But one of the issues in our market, and again, this is an issue of liability law here as opposed to other countries, is where, other countries, the loser pays the litigation costs of both sides. They pay their own for defending themselves, and they pay the other party that prosecuted the case. Now, how would that affect medical liability? If you were an attorney and you were taking on a medical liability case, and you were, let's say, suing a hospital or a doctor or whatever it happened to be, and you knew that if you lost, you're going to have to cover the hospital or the doctor's defense against your suit.
You would be much more
You might
judicious.
be more careful in what you do, because to lose,
has a higher cost.
Many are settled. Okay, so we understand many are settled, probably most, frankly. But you would sit there and be a little bit more judicious, because you know all of a sudden that if you lose out of your pocket as the attorney, because remember, most people in liability suits don't pay their attorney. Their attorney takes it as a part of their fee, which is substantial. It's a third plus expenses typically. They're going to bear not only that, but whoever they were suing if they lost. So you might see that happen. Now, the other thing which is controversial in the medical world is that we have to reduce barriers to entry, whether that's in licensing or in training costs. Now, as an example, I've had the privilege of training both young physicians in residency as well as mid-levels, physician's assistants and nurse practitioners for many schools here in Wisconsin and elsewhere. And you know, I'm incredibly proud of the team that I work with right now, who are doing and have been doing, as we've been interacting this afternoon, in very complicated cases. And they know that they have me as a backup, plus other people in the facility that can help them, plus that radiologist, plus those other people, and skilled consultants who they can communicate with and get expert advice. But we need to see more of that. These are many times working moms who have, you know, quality of life issues, so they don't always work full time because they're doing other things in their life, which is great, but they still have that sense and capability of doing it. And they have a handful of years as a professional nurse before they do 2 years of nurse practitioner education before they're out. And yes, they, you know, benefit from time and experience, just like I do. But as opposed to 8 or more years of medical school and training, often 8 to 12 years of training, they start earlier. And again, in my mind, they're not complete replacements for me, but they are extenders. They can see the person who I was here with on Friday pushing a baby stroller and going to the park with a grandson, and see the person who that was the only time they could get in to be seen because of family transportation of a person who had an event, and order the appropriate tests. Yes, they contacted me and we pre-discussed this. And I can call that person's family back tonight and say, here's what the results are. And yes, we already walked through, did that person need other levels of care? So that, in my mind, they got the same level of care as if I was there doing it. Now, we'll see more of that, and we'll need to see more of it, and we need to expand the supply of doctors, MDs, DOs, as well as the mid-levels. And the way to do that is to realize that right now, those training slots are capped because much of it is reimbursed by Medicare.
Interesting.
So you can expand the number of medical schools that you have. Like in Texas, we've added 5 medical schools, and the population has grown a lot. But do those people have training slots that are required for licensure and board certification, which is an important step in their professional careers within the country? In many cases, no. Now, if they're entering primary care, it may be easier. If you're going into specialties, it may be impossible to get a dermatology residency, right? And you wonder why it takes 3 months to see a dermatologist and why they make a lot of money. Good for them. Because we have a guild-like mentality that restricts access to some of these fields. That needs to go away. Maybe it has to go away because the government doesn't fund it, and the people who are going into it fund it themselves, and I know that's expensive, and added to $300,000 of medical school debt may make it harder for them to choose primary care specialties because they're never going to make that kind of money, right? Or organizations and patients are going to have to figure out how to pay them to have access to those people. But there will be some solutions to that.
Well, and this is where I think when we look at the overall challenge, unfortunately, a lot of what we have to see happen either has to be, in many ways, a very serious overhaul of Medicare, which will be politically suicide.
Well, no, you just have to rationalize how it works. And the government, similarly, is probably unlikely to give up their price controls of what they pay because they can't afford to. But you may see, because right now, Medicare is the only, quote, insurance that you get that you have to buy insurance for. I mean, you either buy a Medicare Advantage program, which is essentially private insurance for your insurance, right? And what they get is the price controls and they then provide everything else. And sometimes they give you gym memberships.
That's
right?
nice.
Because because that's the reimbursement. Or you buy Medigap insurance. So you're buying insurance for your insurance, right? Because Medicare goes to a certain point, legislated in the 60s, made a lot of sense then, but the world has changed since then. And that doesn't make a lot of sense elsewhere unless you're in England or Canada, where people buy private insurance also to cover the things that they can't get there. Like I can go to Minneapolis and get my hip replaced under private insurance from Canada, but I'd have to wait 12 months for my hip to get replaced in Canada because they only get to do X number in certain places because that's what their budget is, because it's a politically designed thing. Now, when I was a little guy and I went to doc and I had a sore throat, if Jane didn't already figure it out ahead of time, bless her heart, but I got to see the doc and he would look in my ear and then see if the light went through to the other side. He did that. I must admit, I was so stupid then because I didn't notice the joke. He had such a wonderful dry sense of humor. I've tried to emulate him in my career. There would be a line on a card that said sore throat penicillin for that visit. Maybe even no vital signs because they probably weren't relevant to his decision. Just so that he knew when I saw it and what he gave. And that would be the note. Your mother's medical records for the first 18 years of her life are on one piece of paper, which, by the way, we have.
Wow.
Back in front of one side, from her well baby care to her, sports exams as a high schooler and everything else in between on one sheet of paper back in front. Right now, medical records through electronic medical records are, a given visit with all the documentation thrown in it to justify through insurance providers that you knew all this, covered all this, could easily be 10 pages for a visit. And it may be a straightforward visit. And when you add in the data centers required and all the energy provided and the fact that they're still not terribly interoperable between one system and another, we've added all this mostly to satisfy billing and insurance requirements. Do we really need all that? Does it really add to care? I don't know. Obviously, we need to know that what you did, you documented. But are we going beyond what is appropriate to see that fraud doesn't occur? We don't want that. But to the point where we've now added costs. So as an example to a common system, I remember this at the time, now almost 20 years ago, when we were looking at and using Epic, which is the largest electronic medical record system based in Wisconsin, by the way. An amazing system, still growing worldwide. It was like a $20 million upstroke to just get access to the license.
To buy it.
Plus all the customization that you bought the software, you had to buy through consultants or hire people to then customize it to work within your system, as many software systems are, at great expense. And then you had to maintain it, and you're paying licensing fees, the bazillions of dollars. And what that eliminated was medical transcriptionists. Now you can say that voice recognition can do that. I'm not so sure. Medical
transcriptionists, I remember you as when I was a kid would sit at the kitchen table and would do dictations into the dictaphone. Their job was to take that and then document it into a digital format of some kind.
And make it into English.
And put it in, really pretty good at it because they certainly can read your handwriting.
That was a skill.
Yeah. And so you're saying that one of those things that was that medical transcription, probably nowadays with the advanced AI we've got for voice transcription, could probably handle that pretty well.
Yeah, but again, scribes, all that often can't understand because you're not saying it out loud, or something or someone can write it down. All the things you're thinking about, taking into consideration as you may be talking to the patient, looking at their allergies, their kidney function, their other medicines, or their history. And you may be synthesizing that, not always in front of the patient or a student, as I often do, but doing it in your head.
Yeah.
While you're asking them about, how's it going walking to the mail basket? Did they go on their vacation and see their grandkids, or did they not feel well enough? You're talking about other stuff while you're looking up and making sure you've got those details in mind before you say, oh, this would be the right medicine, because you need to check those things. So again, part of what needs to happen is to unwind some of the good intentions that happened, get it to the point where people are protected, because medicine is, and healthcare is, a social goal. But health insurance has, to use an insurance term, substantial moral hazard, in which if it's insured, people will use it, where moral hazard doesn't really exist except for arson for home fire insurance. You don't want to burn your house down. All right. If it gets struck by lightning and burns down, you're really happy you have it. But it's 1/2 or less of the asset value to insure every year. Whereas when you're looking at health insurance, because of not only prepayment and the administrative cost to pay for that, and all of the back and forth of negotiating, and all the games that are played with that, and all the ways that profit is protected, held, transferred from one organization to another, you pay ultimately a great deal more. So,
because you're expecting and you want to get the most you possibly can out of your insurance because of that. So like you said, the moral hazard of your fire insurance, you don't want to burn down your house. You don't want to use that insurance.
You want someone to
health
explain to you, if I need an MRI, what's it going to help me? How are we going to use that information? And you want the doctor to be compensated for the time he spends. Otherwise, the compensation is for him to see 20 people a day and buzz in and buzz out and write for expensive specialist procedures, tests that may or may not add significantly value, that he cares nothing about its cost because he isn't either paying for it or not. He actually sounds like he's the best doctor because he ordered something, as opposed to explaining to you whether that was going to really help you or not in a timely way. And if it was, great, let's get it done. But if it's not, let's skip it. I mean, the test that I'm going to call this person about tonight is an expensive test. It needed to be done. There was no other test that I needed. My helper, my nurse practitioner, had collected all the other clinically relevant information to exclude other causes. And we had a straightforward test that we needed to get an answer. And then I can provide advice to the family and to the patient about what to do next. And hopefully make sure that we haven't missed anything. Unlikely. I think we've already covered it. That's team care. That's expensive cognitive care. That's primary care. That's where you get, again, at the lowest level of care, often the best value for money. And if people are actually paying for it, they will get better primary care. They will be happier. And it may not be from me, a dinosaur physician with 40 years of experience. It may be who my first patient, my first day in residency, was a guy who ultimately had a diagnosis of AIDS, which we didn't even have a name for then. And I, had wonderful experience in that training setting, but who are able to essentially spend the time, have better patient relationships. I'm proud that my 2 nurse practitioners have quality scores as good as mine. Patients love talking to them, almost to the point where they're more happy to see them than me, which frankly is good, because I'm happy that we could train that next generation of people, because who am I going to see when I get sick? Right now, me and my older partners were sitting there going, whoa, we better take good care of ourselves. I better keep exercising and eating right, because I don't know who's going to be around and what the system's going to be like in 10, 20 years when I'm consuming more healthcare resources than I am right now. And that's where we have to unwind some of this, or it will simply begin to further implode. And people won't be able to get health insurance.
Well, and I think one of the elements of this is, what can you do as an individual? I think, like we talked about, obviously, first off, share this with other people, because I think education on how did we get here is really important, because it's such a complicated system that most people don't understand why we're here. They don't understand how we can how it could cost $24,000 to have a baby. And the answer is, well, it really doesn't. It depends on who's paying for it. Then it costs what it costs. But the point is this. So share this with people who you might think is relevant. I know it's a long episode. I'm hoping we covered a lot of good things in it. There are things that I'm sure we didn't cover that are aspects of this.
Absolutely. And I'm not an expert at all of this.
This is a million page essay that could go into this, because because this is not one thing. It's 1,500 things over the course of a century and a half, and it's a difficult process because it is a social good.
Which is why Apple and major tech companies have failed. Why Walgreens is pulling out of primary care. Why Walmart is closing their primary care sites, because doing it the way we've done it, with the system the way it's designed, is almost impossible to beat what I'm going to refer to as entrenched interests of pharma providers, and I'll include physicians in that group, hospitals, and insurers. They have way too much capital, way too much privilege in the market, and they're not going to give it away.
They aren't. And that's an important element to this, is that share this with other people, because by educating other people about what this is, when the political discussions happen at the high level, you as the voter can be informed enough to be able to see what needs to happen.
And understand that if changes are recommended through the legislative process, through your employer, you can begin to see how through innovation perhaps, and through relationships with a primary care physician, you can get better care for less money, have more of the income and productivity you generate accrue to your and your family so that you can buy maybe a better house or a better car or better clothes or the things that you want, vacations or whatever is appropriate. You get to make those decisions as opposed to them essentially coming out of your paycheck before you get to decide.
And I think an element of that to think about as well as this is that you should be asking your doctor every time you go into the doctor's office, anytime they want to do a test or anything, you should be asking them, will the results of this make a significant impact on your medical decision? Right? Will this have a significant impact on your diagnosis? Because sometimes doctors don't even think about the cost associated with the thing that they're ordering because they're not trained to. They don't think about it that way because they're trained to avoid liability, which to some extent has its advantages.
And yet if they know that that's a consideration to you and that you are willing to listen and work with them to understand the pros and the cons, they, as you found out with the most recent delivery of your recent son, will be willing to say, I think you're right. Maybe that diagnosis that we were concerned about isn't really relevant at this moment in time, and that we can proceed with a less invasive approach. Now, we certainly wouldn't have wanted a catastrophic outcome. You certainly wouldn't want that.
Of course not.
But if you approach them, they can work with you. Whereas if you just blindly go in, they're likely to be driven by those algorithms that are there to reduce their liability, frankly, the amount of time they have to think about it, and
the hospital's liability, right? To some extent. So being able to ask your physician, is this the best cost-saving, result-driven decision-making we can? So express to them that you're a price-sensitive customer. Even if your insurance is great and it's covering everything, at least express that, because to some extent, this isn't going to be an overnight thing. This is going to require a massive groundswell movement at the individual level of everyone saying, how can I reduce my cost, my consumption of this? Because while we wait for more doctors, more mid-levels to become part of this physician pool to help reduce our costs through basically competition and access to resources, economically speaking, while we wait for that, the simplest solution is to reduce the overall demand on the system for things that aren't necessarily doctor required to make the decision, right? That concept of using AI or Amazon Pharmacy, not to recommend them, but just as a concept, or using telemedicine.
And keep good records of your own. So you are an informed consumer, you go to the doctor, that you have a good medical record of your own, of medicines you've used or ones you had problems with or hospitalizations or the things that they did. I'm surprised by many people who come in and don't know what happened to them. They know they were in the hospital, they know they had a surgery, but they can't tell me whether they had a polyp on a colonoscopy and hence need more reasonable screening at an earlier age, or they didn't. And that's where, keeping records, using your little journal, right?
Yeah, absolutely. Write that down. Keep that stuff in that good journal.
Or taking the money that you might have spent on an unnecessary piece of medical technology or testing or whatever advice and saying, I'd rather, buy a journal that I can write my memories in so that my grandchildren and children can be thinking of, well, what was the world like? And how they can essentially make better choices for themselves because they're more aware of those things.
And this is an important element as well. You need to ask, so you should get involved at your place of work, whether you're a self-employed business owner like myself, or you're an employer and you have employees, and whether you're just an employer or employee at a company. Get involved in the conversation and start asking about what are creative options for us to do, right? Because there may be alternatives like Samaritan's Ministry with this health sharing program that I'm part of, or similar innovative methodologies of how we can disperse this cost, we can diversify some of this risk, that are more cost effective. But because of the entrenched natures of the players, and because a lot of these businesses are not necessarily looking to change, and because there's not necessarily a reason to from their employees' perspective, right, or employers' perspective, having people ask questions, people get engaged, people go research options, and everyone start to take an effort into saying, what can I do personally to look at alternatives? That will hopefully change the system, because for too long, we've gotten comfortable with the status quo, and what's happened behind the scenes is the monster that is this, cartel-like system has started to suck up more and more and more and more of our economy.
All through good intentions.
All through good intentions, and with people who believe that they are on a mission from God, right? Which is not a bad thing, right?
And legislators of all stripes, of all parties, forever trying to make the best solution for the community at the time. But part of what you should think about is that probably based on the dramatic expansion of healthcare expenses, again, in comparison, not every comparison is equal to other, what I'll refer to as developed or rich countries, the equivalent probably would be about the equivalent of adding about 10% to your income. And I don't know anybody who thinks they're not making enough money, and 10% more would be about right. But if we all did better on healthcare, both diet, exercise, taking care of ourselves, being attentive to symptoms and not blowing them off, to eating or drinking moderately, to not doing things that could harm our health, like as an example, smoking cigarettes. That's it was a big thing when I was younger, and many of your grandparents died of smoking related illnesses, but now is uncommon. If we did that, it'd be like getting a 10% pay raise directly in your pocket. And what could you do with a 10% pay raise?
And it's hard to see it. And it's hard to see it because whether you use the insurance or not, you're paying for it. Because of how broken we've created this broken system that disconnects payers and payees and recipients of the goods and services. And so this is where I go back to saying you should be working to evaluate how you can bring the relationship with your hospital closer and closer to the old Marcus Welby methodology of you go to the doctor and you pay as much as you can out of pocket and you work with them and you have as little insurance as you possibly can and you work on figuring out how to negotiate with them. And negotiating your medical bills is something you can do. This is another thing that most people don't talk about. The hospital does not expect you to pay retail prices. Nobody pays retail prices.
They'd like it though.
They'd love it if you did. And they're not going to tell you that you don't have to. But you should be negotiating on your own behalf. You should look at their financial aid programs. If you're paying out of pocket, especially like me, you should look at their financial aid programs. You should look at the opportunities to say, if I pay you today, how much of a reduction can I get on my balance? If I pay you cash right now, can you drop my bill to 60% of what it is on paper, right? A lot of times they may go for that because they don't expect to see a lot of that because medical debt, as we talked about, is an enormous source of bankruptcy in this country. So medical debt is huge.
And they also don't have to wait 90 to 180 days to get paid.
Yes, so there's a financial incentive for them.
That's the delay in getting paid by many insurers is that long. And think about it, you have to capitalize your business
while you're waiting for that payment.
Waiting for payment. And again, there's a fair amount of risk and obviously money that's diverted to that. So my point to a lot of people is be a wiser shopper, realizing that if we make any changes in this way, the initial changes are going to be more obvious and painful initially than the downstream benefits. But we'd like it to still be a good system, the best system for our children and our children's children. And right now, at going from 3.5% in the 30s to now focusing that probably by 2030, it's going to be 20%. Now, granted, in the same period of time, cars have become more expensive and probably safer. Thankfully, that's a good thing. But we can be better to make a decision about whether we really want to spend a quarter of our GDP on healthcare or whether we would probably do just about as well with 15% of our GDP for healthcare, which would still be more than many other nations, and the other 10% of our GDP going to something else.
Yes. And that's where for us, like I said, I think the best thing you can do is share this video, get people educated on this topic. So when policy discussions come up, when decisions have to be made, when individuals are talking to their doctor or individuals are thinking about what insurance they should get or what they need, or when they're talking with their employer about what their employee health benefits look like, or whether you're an employer yourself and you're evaluating what medical program, what health insurance to get for your employees, being informed on how we got here and what is going to take for us to get here is going to be really, really valuable. So please share this with everyone you know. It helps to get more informed on this. And obviously, please go and buy leather journals from the Murdy Creative Company because it does help us continue to put on this amazing podcast. Thank you for everyone who has watched thus far. It's obviously quite a long podcast. Thank you so much, Dad, for coming on here and expressing all of the knowledge and history that you have lived through and obviously researched in great detail. I appreciate that. And please go check out murdycreative.co, MURDY creative.co for the very best in made in USA leather journals, leather binders, leather folios, leather briefcases.
Used every day.
Yeah, all sorts of great things that we offer. They're made right here in the United States. They're made from the best leather you possibly can. And we pay our people pretty well. So we take good care of our people, and we really appreciate all of those who've supported the company in our endeavor to do that. So thank you guys so much. Have a great day, and goodbye.